know that temporomandibular joint is a loose-fitting, rotating, sliding joint, inguinal-arthroidal joint, football-shaped condyle. Then it is covered by a fibrocartilage, which is less discernible when compared to hyaline cartilage, probably for the functions that it performs. And we all know that there is a beautiful disc that is present in between the condyle and the glenoid fossa. Now the disc is avascular and predominantly made up of collagen. The disc is biconcave in shape. The disc is thinnest in the center. It is called the intermediate zone. It is thinnest in the center, and the posterior band and the anterior band are thicker than the central region. So this is the condylar, this is the condyle, the glenoid fossa, and this is the disc. The disc blends itself into the cartilaginous tissues. I mean the capsule, sorry, the disc blends itself into the capsule, and some studies have observed that a miniature of people, what is observed is that disc also is attached to the lateral pterygoid muscle. That's not a routine phenomenon. It's observed only in few people. Now you can also see the two arrow marks here, where you are seeing the lateral pterygoid attachment to the condyle. This is the retrodiscal lamina, superior and inferior lamina, and in between the superior and inferior retrodiscal lamina, you see these loose tissues, collagen fibrils, vascular tissues forming the retrodiscal tissue. I am not going to discuss about the nerve supply, lymphatic drainage, dynamics of the joint. No, this is just to brush through and tell you just that what exactly are we talking here about. Of course, this particular joint along with the disc perform the movements that is necessary for mastication and other things. Now we have musculature performing these actions, the masticatory muscles, and to a lesser extent, the other supporting muscles. The main masticatory muscles are temporalis, the lateral pterygoid, the medial pterygoid, and the masseter. And the accessory muscles of mastication, the hyoid group of muscles, the digastric, and indirectly acting accessory muscles, the trapezius and the sternocleidomastoid. So these are the things which we will be dealing about. Now, before starting the lecture, I would like all of you to understand and realize two things about TMJ, the temporomandibular joint. My dear friends, I would like to say that this particular joint is extremely unique. In contrast to all other joints, extremely unique. There are a lot of unique features of this joint, but as clinicians, we need to remember two things. Point number one, this is the only joint that performs maximum number of movements in the body, averaging to about 3,500 to 4,000 movements. We don't realize it, is it not? We don't realize, but this is what is happening. 3,500 to 4,000 movements averaging per day, TM joint is performing. That is the reason why the time taken for the disease to heal completely is little longer than the problems associated with the other joints. We are not talking about degenerative joint diseases and autoimmune arthritis. We are just talking about the normal musculoskeletal problems affecting the joints. So this is the first unique point. The second unique point that is always helping us is this particular joint has got excellent adaptation capabilities. Excellent adaptation capabilities. If you just look at the amount of adverse loading patients do for this joint, unbelievable. Still patients survive, still patients are comfortable. Only a very, very less number of patients come and seek treatment to us. That is because this is the only joint that has got excellent adaptation capabilities. See, even in diseases like rheumatoid arthritis, what you see is all the joints, majority of them are involved, but the temporomandibular joint is involved only in 11 to 33% of cases. That is why I tell the joint is extremely unique. Now coming to the diagnostic system. Well, for research purposes, they have put forth the research diagnostic criteria, which later got modified in 2014. They modified it into diagnostic criteria of TMD. We have this Axis 1 and Axis 2 classification. We have classification given by Vocation JP. We have classification given by American Academy of Orofacial Pain. But whatever it is, at a clinical level, what we should be learning is a system based on differential diagnosis and description of signs and symptoms. description of signs and symptoms. That is what we should be concentrating on. So I will not be discussing more on classification systems. I will be discussing more on identification of the disease and treating that. So what I will be talking today is accepted conservative evidence-based treatment strategies. Accepted conservative evidence-based treatment strategies, right? Why there is a lot of consensus of treatment in TMD is there are no consistent predictors for this disease. You will be astonished to see that it is very unfortunate to know that the only predictor in assessing the treatment of TMD is a psychosocial factor, a psychological factor, which definitely cannot be taken as a predictor for the treatment in TMD. Now, secondly, treatment of TMD is largely based on the knowledge of comorbid functional pain disorders. Largely based on comorbid functional pain disorders. This is a very, very important thing that we need to know. The reason behind this is if you are not managing the comorbid functional pain disorders, you can't successfully treat the temporomandibular disorders. Number one. Number two, we are so much used to the dental paradigm, we are not thinking beyond this. We are always thinking about the teeth and the musculature and the joint. We are not thinking beyond this. You know, our teachers used to say, eyes will see what the brain knows. So if you do not know about the comorbid conditions, you will not take history pertaining to the comorbid conditions. Forget history, you will not do anything for the comorbidity. Patient will not be relieved of pain and he will go back. So that is why knowledge of this is very, very important. So what do you see in TMD? You see conditions that involve masticatory muscles or joints. Pain is the most commonest presenting symptom. Now, one important thing is pain can be unilateral, pain can be bilateral, pain can be present in the jaw muscles, pain can be present in the joint. Also, patients can present with pain in the neck, pain in the temporal region, pain in the head, so on and so forth. Apart from that, there will be a limitation or alteration of mandibular movements. Then you can listen to sounds. A normal sound that is known as a click that is audible. If this click is more pronounced, it is known as a pop, or sometimes you can also feel a crepitus. And apart from all these things, you will see associations and comorbidities. Now, TMD is associated with conditions like migraine, chronic fatigue syndrome, fibromyalgia, valvular vestibulitis syndrome, depressive disorders, irritable bowel syndrome, restless leg syndrome, and the list goes on. But you should have a thorough knowledge of this. These are the characteristics of TMD. One important thing that we should know before treating this condition is, number one, what we see in the literature is only 5% of them are seeking treatment. Look at the MR studies. It says if you take symptomatic volunteers, the prevalence of disc displacement as per MRI studies is 89%. In asymptomatic volunteers, it is 31%. Now, in spite of this degree of prevalence, we are not seeing much patients in our clinic. That means the joint has got excellent adaptable capabilities, number one. And look at the third one here. Look at the third one. This is based on a 15-year longitudinal study. What they have done is they are taking periodic MRIs. What they have found here is the TMJ disc displacement and bone changes, it can be expected to remain stable over a period of time. And the time frame that they have observed for these asymptomatic volunteers and patients with mild symptoms is around 15 years. So they have studied patients with mild symptoms and asymptomatic volunteers, and they have not seen a great change in the bone or the disc during this 15 years. So it can be expected to be stable. So there is no need to panic. But nonetheless, we will have to be aware of all the etiological factors and then only start treating the patients. Now, let us jump into the etiology of temporomandibular joint disorders. As I told you, it is complex and multifactorial. Apart from etiological factors, there are predisposing factors There are initiating factors and there are perpetuating factors. And again, there is a consensus here. One group of people feel bruxism is an etiological factor. Another group says it is a perpetuating factor or it is a predisposing factor. Whatever it is, for us, we should know all these factors and then only we can successfully treat the patients. So what are the etiological factors? The psychological factors, parafunctional habits, occlusal disharmony, postural imbalance, and trauma. All these things, there is solid proof that these things can definitely cause temporomandibular disorders. But these things are causing temporomandibular disorders. But my dear friends, what we need to recognize is this particular disorders caused by these etiological factors are being greatly modified by the presence of comorbidities. The way pain is pursued, the way patients are suffering, and the way in which the patients respond to empirical treatment is greatly modified because of comorbidities. So we will learn today about each cause, how each of these etiological factor is contributing to TMD, and what is the role of comorbidities in TMD. So let's take up the first one, trauma. Everybody knows what is trauma. Trauma can be of two types. Macro trauma, which is a sudden force, like something like a blow to the jaw, and micro trauma. Micro trauma means it is a repeated small force which is causing adverse loading of the joint. Please underline, repeated small force which is continuously causing adverse loading of the joint. A classical example would be bruxism. Now, research has found that traumatic problems will result more into intracapsular disorders rather than muscular disorders. This is what research says. Now, let's see the examples of trauma. This is a blow to the joint, and everybody knows what is this. The picture on the right hand side is a acceleration deceleration injury called as whiplash. When a person is traveling in a car, suddenly he puts a brake. So there is an acceleration and deceleration movement causing an injury called a whiplash injury. So these are the examples of macro trauma. Then we also have traumatic events like endotracheal intubation. See, our teachers used to talk about this. This is likely to happen. The anesthetic journals have documented it, but there are minimal or no studies. You know why? Because it is self-limiting or reversal. With the trauma caused by endotracheal intubation, patient will have a myogenous TMD, but it will be transient. It will be transient. It is reversible. It will disappear in a week. But what those people have postulated here is, at least if you take a history and if you know already that the patient is suffering from TMD, you can handle the patient in a better manner. Now, another important thing that we need to see is dental procedures. Prolonged dental procedures are also causing TMD. I will come to this point later in this discussion. I have a special slide for that. So we will discuss this a little later. Now, what is this post-traumatic temporomandibular disorder? Patient with a history of macro trauma called whiplash, if they present to you with temporomandibular disorder, it is called as post-traumatic temporomandibular disorder. There is a direct relationship between whiplash injury and TMD, and research has shown that the prognosis of patients with a history of whiplash injury is poorer than the prognosis of a general patient, which is a very, very important thing which you'll have to remember while treating the patient. So this whiplash is definitely playing a role in the TMD. You might be thinking, what is the role of neck and TMD? We will discuss about it later. Microtrauma, sustained and repetitious adverse loading of the masticatory system. Classical examples of microtrauma, bruxism and unilateral chewing. Point number one, let's talk about bruxism. What is bruxism? Bruxism simply means clenching or grinding of the teeth by bracing or thrusting of the mandible. It is proved that it is a sleep-related movement disorder. there are two kinds of bruxism, sleep bruxism and awake bruxism. And it is firmly established that bruxism is a causative factor as well as a risk factor of temporomandibular joint disorders. Now, there are some interesting facts about bruxism. It is a parafunctional habit. The prevalence in the public is about 6 to 8%. And it has been shown that 1 in 5 patients suffering from TND are bruxers. They are bruxers. Now, there is something that you need to listen to. There are these dopamine neurotransmitters. You know what are these dopamine neurotransmitters? Dopamine neurotransmitters are basically neurotransmitters that mediates reward. It plays a role in, it mediates reward. But another important thing is this dopamine neurotransmitters have also proven to be playing an important role in the central regulation of pain. Central regulation of pain. And through polysomnographic studies, what they have demonstrated is, in bruxism, they are seeing dopaminergic sensitivity. Dopaminergic hypersensitivity is different. That is seen in psychiatric problems. This is dopaminergic sensitivity. That means bruxism is also causing pain, not only causing clenching of the teeth. It is associated with microarousals, which is a proof that it is a sleep disorder. Another thing, what you see, there is more amount of EMG activity in the muscles and there are changes in the heart rate. Of course, these are all proven by polysomnographic studies. Microarousals, as you know, recurrent brief awakenings. They are called recurrent brief awakenings seen in sleep disorders. So now this is enough to show that bruxism is a central disorder. It has nothing to do with the teeth, which is having an effect on TMD. Secondly, if you look at the prevalence of bruxism, 8 to 8.6% of the individuals in the general public, they are continuously bruxing. About 31% of general population exhibit some amount of bruxism. That means the frequency and duration of bruxing will be lesser. Maybe they are bruxing 2 days a week, 1 day a week, or 3 days a week, or something like that. But definitely they are doing some kind of bruxing. The proof that bruxism has a direct role to play in TMD is that if you give a splint, or you can take it as a night guard, what we have observed with research is it reduces the number of bruxing events and also the duration of bruxing, number one. And most important point, treatment with a guard is significantly improving the patient's symptoms. See, this is enough to show that bruxism is an important causative factor. I think this one most of us know. I have just summarized the points which are pertaining to bruxism. There is an important point, my dear friends, that you need to know about bruxism. Iatrogenic bruxism. Do you know what is iatrogenic bruxism? Iatrogenic bruxism is a clinician prescribing medicines that is inducing bruxism. Now, the drugs that I have enlisted here is this venlafaxine, paroxetine, fluoxetine, sertraline. These are all selective serotonin reuptake inhibitors. Selective serotonin reuptake inhibitors. Gone are the days where we were seeing other kinds of drugs being prescribed for psychiatric problems. These are the most popular drugs today. I am telling you, see, we don't know because we don't ask people what are the medications they are taking. And even the patients think that we need not know this information. I am telling you, bruxism secondary to usage of these drugs is extremely common. That is what we are seeing. Now, these particular drugs, they are basically SSRIs. They are used for treating psychiatric problems. Yes, number one, it is widely used by psychiatrists. Number two, very, very commonly used by rheumatologists. Are you wondering why? There is something called as Raynaud's phenomena that you see in vasculitis. This particular drug, fluoxetine, is believed to prevent Raynaud's phenomenon. So right, left, center, people are prescribing fluoxetine to prevent Raynaud's phenomena. Not only bruxism, we also get so many patients, rheumatologic patients, complaining of dryness secondary to fluoxetine therapy. But the rheumatologists say, you know, dryness is less important than the Raynaud's phenomena. We would like to prevent that, doctor. Please do something for dryness. So these drugs are very, very routinely prescribed by psychiatrists, by rheumatologists, also by gynecologists. You know why? Premenstrual syndrome. There is something called as premenstrual syndrome. Because of the lifestyle practices today and the amount of stresses that women are undergoing today, the prevalence of premenstrual syndrome has gone up like anything. It is not ending up with just a premenstrual pain. There are a lot of behavioral problems, problems associated with heart rate, problems associated with adjusting yourself with the environment. There are women who will not believe what they have done during those premenstrual periods and how they have behaved. They are not doing it intentionally. The hormones are doing it like that. My dear friends, again for premenstrual syndrome also, these are the SSRIs are the drugs that are being used. These drugs are used by neurologists for treating headaches. That is why it is important to take history. One wonderful thing is it's a reversible syndrome, number one. It can affect anybody. No gene polymorphisms and blah, blah, and things like that. It can affect anybody who are taking this particular selective serotonin reuptake inhibitors. Classically, the patient will come and tell you, we have started this particular medicine about 3 to 4 weeks back, and after that they have started getting this bruxism or pain, whatever. Now it is for you to elicit and take a clearer history and decide whether there is an iatrogenic bruxism or not. Now coming to treatment of this iatrogenic bruxism, we will discuss it in later. There is a pharmacotherapy for that, which we will discuss later. So this is about iatrogenic bruxism. Very, very important. As I told you, very, very routinely prescribed medicines, SSRIs. Please keep that in mind. Unilateral chewing. Now this is something very, very important that we need to recognize. There is no data for this. It is totally anecdotal. That is why I have not given any reference below. It is, according to me, it is very, very prevalent in India. What does unilateral chewing do? It causes adverse loading of the jaw joint. An average individual in our country, do you think he will directly come to a dentist when he has toothache? He never does it. Thanks to the advertisements, educated people are first applying desensitizing agents. Uneducated people are putting clove inside their tooth. That will be the first order of defense for a toothache. Some people chew tobacco. Second order of defense will be they will go to a medical shop. So-called medical shop people will prescribe one course of antibiotic and painkillers. Third time, patient will not go to medical shop. He will be having some tablets remaining, which he has used previously. He will start taking those tablets. Fourth time, he might consult a general practitioner. Fifth or sixth time, after doing all these things, if there is continuous pain, swelling, that is when patient is turning up to us for dental treatment. Predominantly, this is what is happening. They don't directly come to a dentist, majority of them. And let me tell you, during this time, the time when the pain started, the toothache started, and the time when he presents to a dentist, there is a long gap. There is a long gap in between. And my dear friends, during this time, what this fellow would have done is, somewhere inadvertently, he knew that if he's chewing on the affected tooth, it is giving him some discomfort or pain. So slowly he would have got used to chewing on one side. Most of the dental patients, they will start unilateral chewing. Now again, you might ask me a question, why then we are not seeing so many patients? Yes, excellent adaptation capabilities. That is why I am telling you. So these are the patients that we need to look for. With all this unilateral chewing, they come to dentist for treatment. Unfortunately, some people will have narrow canals or varied anatomy of the tooth. So a traumatic extraction or a root canal that is taking more than 1 hour will immediately induce pain. The pain will be severe. It will not only involve the tooth, it will also involve the other masticatory structures, the temporal area, so on and so forth. That is why patients come back and complain to you. We have failed to take the history. Actually, clinically, it will be visible. Most of the times, there will be a lot of calculus accumulation on that particular area. You would have not used that side to eat. No action of tongue and musculature, calculus accumulation. So according to me, my experience is very, very prevalent in India and an important cause of TMD that we all should recognize. So we all should educate our patients not to stop eating from both the sides. If there is any discomfort, please come to dentist. We'll take care of the problem. That is what we are supposed to say. Another important thing, impacted teeth. I get many referrals. People come with an OPG. They say, I have pain I have pain in the jaws, pain in the face, and somebody has suggested that this is because of wisdom teeth, and if wisdom teeth are removed, the pain will disappear. My dear friends, I don't disagree that wisdom teeth can cause pain, but I totally disagree that wisdom teeth can cause temporomandibular disorders. Please, let us not accept these kind of things. And if you look at the OPGs which those kind of patients have bought, the tooth is somewhere deep inside. You will see about 2 to 3 millimeters of thick bone above the wisdom teeth. And that patient is asking you to remove the wisdom tooth. See the irony. Very, very sad. Very, very sad. We should not be doing this. We should not be doing this. Wisdom teeth cannot cause TMD. There is no data to support this. See what I have portrayed here, this is a study done by people from Savita Dental College recently. In fact, what they have told is the incidence of TMD is more after third molar surgery. Incidence of TMD is more after third molar surgery. And TMG evaluation is a must before third molar surgery or minor oral surgery. That is what they have concluded from their study. But I am repeating again, there is no evidence of impacted teeth causing TMD. So please, please, please do not extract the impacted teeth for a patient who is coming with a facial pain as a complaint before evaluating properly and seeing what is the cause. Next, coming to postural imbalance. Postural imbalance. Now we are facing difficult times. Most of us are staying at home. When you are staying at home, you are either doing this or this. Either you are sitting in front of a computer or a laptop, or you are on the phone. Unfortunately, both these things are having an impact on our posture. Now let us see what happens with posture. First, let us see what do studies say. This particular study was done on 92 people using computers in Bangalore. To our astonishment, what was found is 56% of them were females, 44% were males, and out of this, 82% had neck pain, 75% had shoulder pain, 44% had TMD. Whether they are seeking treatment for these problems or it is not necessary. How severe are the problems? That is a different story altogether. But what I want you people to realize is posture can cause this, right? And what they concluded is if a person is using a computer for more than 5 hours per day, for more than a period of 5 years, he is at high risk of developing these musculoskeletal problems. Now, what exactly is the relationship between posture and temporomandibular joint? Now, I want everybody's attention here. On the left-hand side, where the green tick mark, excuse me, somebody from the committee, are you seeing the pointer? The mouse pointer?
Yes, sir. Yes, sir.
Yes, sir. Please go on.
Okay. So, this particular picture on the left-hand side is an individual who is maintaining a right posture, maintaining a correct posture. The abbreviation MC stands for muscle center. Muscle center. So in the human body, we have muscle centers at the back of the neck, chest region, lower back, thighs, calf muscle, and the feet area. Now, if a person's posture is perfect or near to normal, what we see is these muscle centers are opposing each other. Please underline, muscle centers are opposing each other to maintain a physiological state of equilibrium between all muscles from head to toe. Please underline and understand, physiological equilibrium of the musculature, group of muscles from head to toe, is maintained by balancing through opposed muscle centers in the human body. This is a healthy individual. On the right hand side, you are seeing a patient with a postural abnormality. What has happened here? You can see the muscle centers have shifted. The muscle centers have shifted. And look at the posture and the way patient is standing. What happens here is, because of the shift in the muscle centers, the physiological equilibrium between the musculature and the muscle centers is lost. Physiological equilibrium between the muscles is lost. As a result, patient will start experiencing spasm and pain. Because the equilibrium is lost, patient will experience problems with spasms and pain. Another important thing that you will have to realize here is this group of muscles, what they do, if one group of muscle is under spasm, the spasm and the pain is again shared by the adjacent group of muscles. So it is not necessary that one area of muscle center is disturbed and nothing happens to other centers. Entire body will get affected. Now these things were first demonstrated by two investigators called Gelb and Bernstein, who run a TMD clinic in USA. You know, they have done studies where they have correlated ankle joint pain and TMD, low back ache and TMD. They have also gone to the extent of proving that if you wear high heels, it can cause TMD. That is the degree of impact that the posture has got on your TMD. Majority of the people, if postural imbalance is there, definitely they have a high risk of developing TMD, and it is proved. Let's look at an interesting study. Now, this study was done on a group of children. Their age was in between 10 and 15 years old, with a MR diagnosis of disc displacement with or without reduction. To our astonishment, what they have seen is majority of these individuals had forward head posture, lumbar hyperlordosis, and genu valgus. See, this is the forward head posture, and this is the lumbar hyperlordosis. There is a change in the way the lower back is positioned. That straight posture is lost. There is a curve here in the low back. And of course, the genu valgum was very, very minimal. Genu valgum was seen in very minimal number of people. But forward head posture, lumbar hyperlordosis was very, very common in these patients. I think it is enough to show that definitely posture has an important role to play in TMD, and it is a etiological factor causing TMD. Now, the most debated and controversial topic, occlusion. See, I told you in the beginning that I am just discussing my experiences and whatever is there in the literature and what I have adopted. I am not for or against anything. Occlusion is most controversial topic. If you look at the literature, there are about 2,419 published papers on the relationship of TMD and occlusion, out of which around 52 are randomized control trials. Keeping apart all other findings, the final conclusions that they have drawn from these studies is that the temporomandibular joint accepts and adapts to occlusal alterations. That is the conclusion that these people have given, that it accepts and adapts to occlusal alterations. So again, we'll go back to the uniqueness. I told you it has got excellent adaptation capabilities. Same thing is proved on the basis of studies. Now, second important point, most of the patients with TMD have got normal occlusion, and majority of the people with malocclusion do not have TMD. I think you should agree on this viewpoint. I am not telling. American Academy of Oral Medicine is telling. Now, this slide is exclusively for people who feel if you do fixed orthodontics, TMD is going to resolve. No, there is no data on that. And there is also data that if you do fixed orthodontics for TMD, it is worsened. So please do not advise anybody to undergo fixed orthodontics if they have TMD. There are a subset of people who come to me and ask for orthodontics. Number two, there are studies which have shown that even in class 3, on performing orthodontics and orthognathic surgery also, the symptoms of TMD have not resolved. I am talking about patients who are suffering from TMD who have class 3 malocclusion. There are studies. So please don't advocate fixed orthodontics for temporomandibular disorders. Occlusal disharmony definitely can cause TMD. I agree. Yes. High points in fillings. If there is a recent filling with a high point, yes, definitely they can result in TMD. You get rid of the high points, patient will start feeling better. Then what about Carsten syndrome? That also holds good. Edentullousness, loss of vertical dimension definitely can cause pain in the TM joint. But what they have proved is partially edentulous people are more prone to exhibit TMD signs, and masseter muscle tenderness is very, very common in these kind of patients. It's very, very self-explanatory, is it not? Because the amount of adverse loading that they do if they are partially edentulous is much more then the kind of adverse loading that they are doing if they are fully edentulous. At least they are eating in a symmetrical fashion if they are fully edentulous. If they are partially edentulous, eventually they will end up doing unilateral chewing. Comes back to square one. So this is about edentulousness. Next we will see parafunctional habits. In parafunctional habits, we have cheek and tongue biting, finger and thumb sucking, unusual postural habits. They all contribute, predispose, initiate, or perpetuate temporomandibular disorders. Now, we come to a very, very important point. Psychological factors. Psychological factors. See, what I'm trying to tell you is, there are certain things that we need to remember here. See, we should not be thinking that whether it is established that depression or anxiety is present prior to the initiation of TMD, or whether TMD is causing depression. Let us not get into these kind of debates. Let us not get into these kind of debates. See, psychological factors are 100% related to TMD. 100% related to TMD. I can say it is etiological factor, perpetuating factor, initiating factor, everything. Everything. Studies have shown very, very strong association between depression, anxiety, mood disorders, somatoform disorders, hypochondriasis, or whatever. All the psychiatric and psychological problems are very, very strongly associated with temporomandibular disorders. Now, why and how does it happen? We need to have an explanation, is it not? We cannot just say, just because the studies are telling, we should accept it. Now, I need your attention here. We all know a person who is stressed will start clenching his teeth. A person who is stressed will start clenching his teeth. Now, what happens when you start clenching your teeth? You are doing an increased muscular hyperactivity. You are over clenching. When muscular hyperactivity is more, what happens? There is a change in the ATP and pH in the muscle. When this chemical change happens, what happens is the muscular afferents to the brain starts bombarding, especially the nociceptive muscular afferents. The meaning is the pain carrying sensory fibers from the muscle to the brain starts bombarding because of muscle hyperactivity. Because of muscle hyperactivity. This is one reason. Second reason, all patients who are under psychological distress, they have a modified pain reaction to pain. I can explain this in simple terminologies. Let us imagine there are two people. One person is happy and one person is sad. If you slap them, the person who is happy probably will feel some pain, and the person who is sad will experience more pain. That means the brain's perception of pain is modified because of the person's psychological problems. That is why there is a modified patient's reaction to pain. That is how psychological patients have more TMD. Third reason, when you are clenching because of stress, steroid hormone is released in the body. Steroid hormone acts on the muscle. It depletes the glycogen. After depletion of glycogen, there is further fatigability of the muscle leading to pain. So these are the causes which will lead to pain in the temporomandibular joint and the masticatory complex. There are many studies which show that there is a significant relationship with depression, anxiety, and stress. Depression and anxiety are the most commonly seen psychiatric disorders that are associated and strongly associated with TMDs. To summarize again what we have discussed so far, we have discussed about psychological factors, we have discussed about parafunctional habits, we have discussed about occlusal disharmony, postural imbalance, trauma, all the etiological factors we have covered. The next lecture we will see what is a comorbidity and how it has got an impact on the temporomandibular joint and the masticatory system. With this, I am ending my first lecture. Many thanks to all of you for patient listening. My acknowledgements to my teachers. Yes, organizing committee, over to you. Dr. Sarma?
Sir, I'm here, sir.
Yeah.
So thank you, sir. Thank you for taking us through the etiology and the basics. So we'll have a short break, sir.
Yep.
So next we will move on to the preliminary round of the quiz.
Okay.
The participants, there are certain instructions. Kindly follow the instructions. The link of the Google form for the quiz will be shared in your chat box. All the interested registered participants can respond to the Google form. All the participants who would be responding to the quiz use the same email ID through which you have registered for the program in your Google Forms. And 15 questions would be given and the time limit of 15 minutes. And the first 100 participants with the right answer will be qualified for the main round of quiz. The link for the main quiz will be sent to your own mail IDs of the qualified participants only. So kindly check your mail IDs and request all of you to join back after a few minutes of break. Might be 11:15. I would like all of you to join back in the same link. So the Google Forms will be the Google Forms connection will be cut within 15 minutes. So we'll allot 15 minutes for you to go on with your Google Forms, answering your Google Forms. And after which you can have 10 minutes of break. Please join us back by 11:15.
So we'll get a 10 minutes break now.
Yes, sir. Yes, sir. Nearly
Thank
20
you.
minutes break, sir.
Okay. Okay.
After which we'll have 2 sessions of yours, sir. Then we will break for lunch.
Okay. Okay. Fine.
With this quiz and then break for lunch. Okay, sir. For the participants, the link is being sent in the chat box. All of you can start answering. It is also being sent in through your WhatsApp. You can have a check there also. Welcome back. We are happy to inform you that there are nearly 255 participants who have responded to the preliminary round of the quiz. The top 100 from this list would be selected and shortlisted, and they would be sending the link for your final quiz through the email IDs, which has been provided in the Google Forms. The code will also be given. The other instructions will be given to you as we proceed with the quiz after the 2 lectures. The second lecture for the day would be on comorbidities and the temporomandibular disorders, which would be followed by the clinical features and imaging. Over to you, sir. Sir, over to you, sir. You can start sharing your screen, sir. So yours is on mute, sir. Please unmute and you can start your screen sharing.
Am I audible?
Yes, sir.
Can you see my screen?
Not yet, sir.
Somehow this button doesn't seem to be working.
Button doesn't.
Screen
1
share.
minute. Yes, sir. 1 minute, sir.
I'll have to click all participants. Is it here? Can you see?
Try now, sir. Yes, sir. Try now.
Can you see my screen?
No, sir, not yet.
Now?
No, sir.
I don't know. There is some problem.
We'll also check here, sir. A moment, please. So could you please close and again join back, sir, and try again?
Yeah.
So please try, sir.
Yeah.
Yes, sir. Yes, sir. Done. We are able to see, sir.
Yes.
Yes.
Welcome back to all the participants. So we will just continue with our lecture. Gone are the days where people did not know what is the meaning of comorbidity. All of you know the reason. The effect of comorbidity, the entire mankind is facing today. I think even a common man understands the meaning of comorbidity today. The way COVID-19 infections are behaving in patients with and without comorbidities, all of us know. I think that is enough to show what is the effect of comorbidity on a particular individual, on the way he suffers from the infection, on the way how he responds to an infection, and also the prognosis of a particular infection. Whether it is infection or a condition, comorbidity is very, very important. So what exactly is a comorbidity? Comorbidity simply means more than one illness or disease occurring in one person at the same time. More than one illness or disease occurring in one person at the same time. So what are the comorbidities that are associated with temporomandibular disorders? I have given this in decreasing order of prevalence. Number 1, headaches. Number 2, cervical vertebral and cervical muscle dysfunction. Number 3, fibromyalgia. Number 4, low back pain. Number 5, irritable bowel syndrome. Number 6, chronic fatigue syndrome. Then there are 2 more conditions with very little prevalence, namely the interstitial cystitis and restless leg syndrome. Unimaginable, is it not? Pain in the urinary bladder region and temporomandibular joint. Unimaginable. See, this is where we stand today. Restless leg syndrome. Patient will start feeling an itch in the leg. He feels like moving the leg. That disease associated with TMD. See, the central mechanisms have changed. See, recently we have started seeing a lot of burning mouth syndrome patients who are moving their tongue. I don't know whether you people have seen or not. So all these things are centrally related. So coming again, these are the comorbidities that we are supposed to know. These are the comorbid disorders which are causing a change in the way TMD behaves, the way it responds to treatment, and the way it responds to empirical treatment also. Now, my dear friends, to understand what is the effect of comorbidity on TMD, what exactly a comorbidity does to TMD, it is a very, very little dicey, because you will have to have a basic knowledge of the pain pathway to understand this one. Now again, let me tell you, I am not going into details of I am not going to explain any pain pathway in detail. I will put 3 slides where I will just name and tell you how pain is carried to the brain. I will try my level best to explain. Let's see how it goes. Now, what are you seeing here? You are seeing, let us imagine this is a temporomandibular joint area with some amount of inflammation. Pain is carried to the brain in this manner. The pain carrying sensory fibers are called as nociceptive fibers. Now, the fibers which are going from the joint to the spinal tract nucleus, this is known as the first order neuron. It enters the brain system to synapse with the second order neuron. The second order neuron connects the first order neuron to the thalamus. Second order neuron, connects the second order neuron to the thalamus, and from the thalamus, it goes to the cortex, that is the third order neuron. That is where pain is interpreted. I think everybody knows this much. First order, second order, and third order neurons. How pain is carried from here to here. Right? Now, we should know that whatever is the degree of, we have taken the example of inflammation. What we need to understand is the degree of inflammation in this area is not always directly proportional to the amount of pain that is interpreted in the brain. That means there are a lot of mechanisms centrally and peripherally which are playing a role and modifying the way how pain is perceived in the brain. Please understand. We have learned so many changes in the perception of pain during our undergraduate level itself. And you all know it. For example, we have studied about the gate control theory. Now, what is important for us to know is the pain transmission in our body goes through the spinal tract nucleus, the dorsal root ganglia of the spinal nerves, which is called as the substantia gelatinosa. What happens in the substantia gelatinosa is there is a modification of the sensory input of the pain. Now we will just have 2 examples. You all know C fibers and A delta fibers. C fibers are slow conducting fibers, A delta are fast conducting fibers. if there is a continuous bombardment of A delta fibers, the gate, the substantia gelatinosa, will close the impulses after a certain time. That is why we don't get to feel severe and acute pain in a continuous manner. Most of the times it tries to be intermittent. Whereas if it is a chronic pain, it's transmitted by C fibers and the gate is always open. That is why a chronic and dull aching pain can be continuous. 1 point. This shows that the gate can decide what to transmit and what not to transmit. Number 2, a non-painful signal. For example, you are sending a signal, you are stimulating a muscle by something called as acupuncture or a TENS. This is stimulating your A beta fibers. This stimulation of A beta fibers is closing the gate. That means you are keeping the substantia gelatinosa busy by stimulating A beta fibers. What it does is it is not allowing the painful stimuli to the brain and patient is getting the relief. First point. Second point, this gate is also capable of releasing what is known as endorphins and enkephalins, the endogenous pain suppressing substances that is also released in this gate. Now, why am I telling all these things to you is all these things are modified in central sensitization. So if you understand this, you will understand what exactly is that mechanism and what happens to the disease process. Now, one important point that you need to recognize. The pain from head neck phase is transmitted through the spinal tract nucleus. The trigeminal nuclei, there are 5: motor, sensory, nucleus oralis, interpolaris, and caudalis. Now, this nucleus caudalis is analogous to substantia gelatinosa. It is analogous to substantia gelatinosa. This caudalis is acting as a gate. Now, the pain is transmitted through this caudalis to the higher centers. Now, this acts as a gate in head, neck, and face pain. So, this is how the pain is transmitted to the brain, and pain is again interpreted in various centers in the cerebral cortex, of course, with the influence of thalamus. With this outset, we will see and understand what exactly is central sensitization. Number 1, central sensitization occurs when something painful stimulates your nerves in the brain repeatedly. Something painful, if it continuously stimulates your brain nerves repeatedly until to an extent where the brain will start memorizing the sensation. Brain will start memorizing the sensation. That means, let us take the example of migraine. In migraine, what happens? Repeatedly, patients are getting headache. So the brain and the brain nervous system gets used to a particular kind of pain in terms of intensity and other things. So it gets sensitized. Brain is getting sensitized. There are 2 hallmarks of central sensitization. Number 1, allodynia. You know what happens in allodynia? A non-painful stimuli can cause pain. People who are suffering from diseases where central sensitization is debated as an etiological factor, a non-painful stimuli can cause pain. That is called allodynia. The second concept that happens is hyperalgesia. Hyperalgesia means a painful stimuli will produce more pain. These 2 things can happen. That is what happens in central sensitization. So to summarize the various things that are happening, we spoke about the gate. There is an alteration there. Poor endogenous analgesia. We spoke about the gate, altered sense. This is about that. Altered sensory processing in the brain. Then increased excitatory mechanisms. Sorry about the spelling mistake here. Increased excitatory mechanism. With functional MRI studies, they have found out there are activated glia in the nervous system. Activated glia means it is a sign that there is neuroinflammation. So these are the changes that take place in central sensitization. So the group of disorders which are debated and discussed with central sensitization, TMD along with the other disorders that I have shown. There is ample proof for proving this. Ample proof. Now, you are seeing a picture here. This picture is a brain region with altered function involved in TMD pain. This picture is based on the functional MRI studies. There are three types of colors of balls that you are seeing here. The green balls are the green balls are representing our classical trigeminal-thalamic tract. Green balls, right? Red balls are the motor systems, and the yellow balls are the areas in the cerebral cortex that is important in perceiving and modulation of pain. Perceiving and modulation of pain. With functional MRI studies, they have demonstrated that in TMD, all the changes are seen in these many areas. Changes are seen in these many areas. I think this is enough to show that central sensation has a major role to play in TMD. So what are the diseases that are linked to TMD based on the concept of central sensitization? Fibromyalgia, chronic fatigue syndrome, irritable bowel syndrome, I told you, restless leg syndrome, vulvodynia, headaches, and primary dysmenorrhea. So these things have a common etiologic pathway. Common etiologic pathway. Remember, peripheral nociception is changed. There are few changes in the gait, and the way brain interprets the pain is also changed. Since there is a common etiologic pathway in these disorders, it is very important for us to understand this so that we can recognize, manage, or co-manage these conditions to manage TMD patients in an effective manner. Let us take up one by one and see what happens. First, let us talk about migraine. If we all know, migraine is a neurovascular headache. Of course, the pain is carried through trigeminal system itself. So point number one, it has got a similar pain pathway. The pain carried from the areas where patient is feeling pain in migraine and pain in TMD, it is the same pain pathway. There is something called a convergence to caudalis. That means the pain carrying sensations from temporomandibular joint area and the forehead area or the retro-eyeball area, they converge at the level of nucleus caudalis so that there is a increase in the signals going to the cerebral cortex, and of course the central sensitization. So all these three put together will worsen the symptoms of TMD and the way it responds to therapy. So you can see that there is a similar pathway. The inputs that the trigeminal ganglion gets is from tooth, muscle, sinus, eyes, dura mater, and also the cervical vertebrae. Everything is getting relayed through nucleus caudalis, and somewhere there is a convergence. There is a convergence. Since there are a lot of undergraduate students and interns in this particular group, I thought I should tell them what is migraine in one slide. I can directly not discuss about management of migraine and other things. So let's simply see what is migraine. In migraine, you see unilateral headache. That is the main symptom. Initially, what you see is you see a prodrome. In a prodrome, about 50% of the patients will have this prodrome, which is characterized by sensitivity to light and sensitivity to sound, which is called as photophobia and phonophobia. Some people will have depression, irritability, lack of appetite. The next thing is they will get aura, A-U-R-A, aura. It occurs prior to headache. About 20 to 25% of individuals will have this aura. Aura means, see, most of us would have seen this. Sometimes what we see is when we are regularly seeing or talking or doing something, we see small flashes of light moving around our eyes. That's the visual aura. But in migraine, you'll also see different kinds of aura. There can be sudden blackouts. There can be a white shadow called scotoma, and there can be an obscure vision. And you will also see some geometric patterns, white colored or black colored geometric pattern that is called as visual aura. Then you will have headache. The headache, it can be moderate, severe, lasting 1 day, half a day, 2 days, 3 days. You see different kind of patients. And apart from all these things, you will see a postdrome. In postdrome, what happens? They will be irritated. They will feel fatigue. They cannot concentrate on things. They will have mood elevations. So many things are happening in migraine. The reason why we are concentrating more on migraine is most commonest comorbid disorder with TMD. We have to know about this. Now, migraine, as I told you, it's a neurovascular headache. Initially, they used to believe it is caused by constriction of blood vessels. Later, they started telling that there is a depression of the cortex in the trigeminal system and cerebral cortex. But now they believe it is a neurovascular headache. There is a problem with the perception of pain. There is a problem with the way pain is sent into the brain, and vascular changes are also brought, and lot of neuropeptides and pro-inflammatory cytokines are also involved in this particular disease. In fact, we have reached a place where we are giving anti-neuropeptide therapy. Anti-neuropeptide therapy. It is not in the purview of this lecture to discuss all those things, but this is where it has reached. Now, what is the link? The comorbidity of primary headaches and painful TMD is very well established in adults. This is based on studies, what I'm trying to tell you. Painful TMDs were strongly associated with migraine. All the primary headaches to a lesser extent, but majority of them are linked to migraine. And what they have told is migraine is significantly associated with a greater number of muscle and joint sites that are painful to palpation in the trigeminal area. Please understand, when you palpate the masticatory muscles in the trigeminal area, patients with migraine are significantly associated with greater number of sites. Number one. Number two, TMD and migraine, when they are present together, migraine significantly improved only when you treat TMD, and TMD improved only when you treated migraine. So if you don't identify and manage these problems together, it is very, very difficult. Now, secondly, identification of this problem is very, very important. So you should have a basic knowledge of all these things. Some 11th and 12th edition Burkett, they have included a chapter on headache. This is the reason for that, but we seldom recognize that. There are a lot of triggers that are present for migraine patients. So you should also warn them about this. Many of them will get migraine if they have some kinds of food, some odors, if they travel, if they skip a meal, if they don't sleep, during menstruation. There are a lot of triggers associated with migraine. So you will have to identify the problem, tell them about the triggers, and also do necessary pharmacological management. Now, pharmacological management for TMD with migraine has to be handled in a different manner. We will talk about that when we are talking about management in the last lecture. But for now, if you understand that TMD and migraine are two comorbid conditions with significant effects on each other, it is more than sufficient. We will pass on to the next comorbid condition. TMD and cervical dysfunction. This is termed as craniocervical dysfunction. That is the neck muscle dysfunction. My first experience with this was in 2001. As a PG student, I had done a study on 100 patients of TMD. To my astonishment, 50% of the patients were having neck problems. And I was astonished to believe that. From there, this journey of neck dysfunction started. What do the studies say? There is a strong evidence linking cervical dysfunction and temporomandibular disorders. Most of the patients suffering from TMD, they have a lower endurance of extensor neck muscles. Quite often we get to see hypomobility in patients suffering from TMD. Then the neck factors, they seem to have relevance with migraine in adolescents with painful TMD. See this, they have linked all the three together. TMD, cervical dysfunction, and migraine. See, theoretically, there are a lot of explanations given for this, but let us not bother about those things. What I am trying to tell you is, if you know that there is an association like this, it will help us to identify, co-manage, and treat the patient in a better manner. See, rather than debating at a molecular level, if you understand that this one happens, it is fine. Since it is a mixed audience, I am just telling it in a gross manner. Last but not the least, it has been shown that physical therapy for neck, if you do, the symptoms of TMD are improving. Randomized control trials. I think this is enough to show that TMD and cervical dysfunction are definitely related to each other. And it is an important etiological factor or a comorbid disease that is having a significant effect on TMD. What the link? We will go back to the first slide. I had shown this slide to you when we were discussing about posture. We spoke about the muscle centers. We spoke about the change in the posture. Here, postural abnormality is changing these particular characteristics. In cervical vertebral pathology, muscle is already in question. There is a problem with the cervical musculature. There is a problem with cervical musculature. Because of that, there is a change in the posture. There is a loss of equilibrium of muscles, and then it causes pain in the temporomandibular joint area. Number one. Number two, it has been shown that bone will yield to muscle and form will follow function. See, why do you think osteophytes are formed in spondylosis? That is because prolonged spasm of muscle will yield to that muscle. That is when osteophytes will form, it will start compressing the nerve and you will start getting pain, ulnar border paresthesia and all those things. So here, it is altering the posture again. And it is very well proved, very well proved. See, this prolonged spasm of a chain of muscle can cause generalized abnormalities and asymmetries and also alters the posture. Now, altering of posture is also very well proved. It has been told that any disturbance of the upper torso muscles, it can alter the posture of Atlantis and axis. See, this area is exactly next to the cervical vertebrae, so it has a it has a greater effect on the masticatory system. Last but not the least, there is something called as central summation. See, we discussed about this. I have shown you this picture earlier. Pain, let us imagine that there is a inflammation in the neck area, sternocleidomastoid. In this picture, what you are seeing, nociceptive input is carried from C3 to nucleus caudalis. Directly, it is interpreted as pain. It is interpreted as pain in the brain. Now, what is happening here? You look at this. What is happening here? The same thing is getting transmitted over here, and it is also getting picked up by this particular second order neuron. So pain is also being interpreted in this area of the brain. In simple terminologies, in central summation, what happens? Pain in the neck now is being interpreted as pain in the TM joint. That is central summation. Very simple. So all TMD patients, examination of the cervical spine, looking at the posture, neck examination is very, very, very important. There is one thing that I would like to share in my clinical practice. All the patients where you see cervical muscle dysfunction as one of the factors, when you are palpating the muscles, if the patient is experiencing tenderness in one of these muscles, let it be the sternomastoid or the trapezius, the patient will also simultaneously experience pain in the TM joint area. If you ask for it, you can know that. You can see patients. When you start examining and start seeing these kind of patients and start doing the palpation of the neck muscles, you will definitely see this. This is my experience. So it is very, very important to recognize neck dysfunction and referral of such patients to the concerned specialist, orthopedician, shoulder specialist, or whomsoever. The next condition is fibromyalgia. You know what is this fibromyalgia? This fibromyalgia is called as an irritable everything syndrome. It's called a irritable everything syndrome. What exactly happens here is, it's basically a musculoskeletal pain. And in this condition, you will have tenderness at specific sites in the human body. Now, the points that you are seeing here in the body, anteriorly, posteriorly, these are all the points where they will have tenderness. Initially, the American College of Rheumatology was giving the criteria that if 11 out of 18 points in these tender points are tender, then you can frame it as fibromyalgia syndrome. You can frame it as fibromyalgia syndrome. But recently, a lot of other criteria are there. Instead of these dotted marks, they have put it as zones. So now you'll have to look for pain index. So you'll have to note down the number of areas where there is pain. Same thing, shoulder girdle, upper arm, lower arm, hip, leg, lower leg. So if there are more than 7 areas, yes, it satisfies one criteria. Then you have symptom severity index. Apart from that, you have to see the symptomatology has been present at a similar level at least 3 months. And thirdly, patient does not demonstrate any other disorder that would otherwise explain the pain occurring in this particular condition. I am telling you, my dear friends, this is a frustrating disease somebody could get. If you look at the symptom complex of this particular disease, you will be astonished. Look at this. Low back pain, headache, arthritis, muscle spasm, tingling, balance problems, irritable bowel syndrome, teeth disorders, whatnot. And look at the percentage. 63% of them have low back pain, 47% have frequent headaches. I will tell you my experience with this particular disease. I never knew that fibromyalgia was a factor to be studied. I was called by one senior periodontist to see one patient in the year 2005. At that time, I didn't know about fibromyalgia. It was a weird complaint. They have finished root canal treatment for 2 premolars. Patient is not having any problem, but they fix the crown. Patient is getting excruciating pain. I went and saw the patient. I kept on empirically managing the patient for 2 or 3 times to get some time and to do reading. That is when I started enlisting all the conditions that can cause pain, and I started ruling out one by one. To my astonishment, she was having fibromyalgia. But I was not confident on my diagnosis. They referred her to another specialist. He confirmed that patient is suffering from fibromyalgia. They started her on pregabalin. I didn't do anything. Patient came back after 3 months to that period, and they fitted the crown and sent her back. So this was the initial presentation of this particular disease. This was my experience with this particular disease. So TMD and fibromyalgia, there is a high prevalence of TMD in patients who are suffering from fibromyalgia. This is the data that I am projecting, which is a result of 185 studies. It can be an etiologic or aggravating factor of TMD. Another important thing, if a person is suffering from fibromyalgia, it's irritating. You know why? He will become generally vulnerable to all kinds of pain disorders. Unexplainable pain. See, you will see some patients complaining, if I walk, I am getting pain. If I do this work, I am getting pain. So they will give all these kind of complaints. And it is for us to recognize this and refer them to concerned specialists and then manage. And why it is important, and why this relation? 2 pathologies are sharing central mechanisms, which is in common. That is the central sensitization that I earlier explained to you. So very, very important to identify fibromyalgia patients and refer them. One important point that I would like to discuss is physical therapy is of ample importance to us, especially in patients with fibromyalgia and patients with fibromyalgia and TMD. Lots of trials, randomized control trials and systematic reviews have shown that physical therapy is very good in managing fibromyalgia. So in my opinion, if a patient is suffering from TMD and fibromyalgia, you can also try physiotherapy as a modality of treating TMD. You can give them splint, you can give them muscle relaxants, all other modes of treatment. We will see that later. But along with that, physical therapy, if you give, these patients respond very well. That can be low-level laser therapy, that can be low-density ultrasound, that can be TENS therapy or MENS therapy. But please remember, physical therapy is very, very good in patients who are suffering from fibromyalgia as well as TMD. Now, with regards to pharmacotherapy also, there is a change that we need to adapt when we are seeing chronic TMD patients comorbid with fibromyalgia, which we are going to discuss in our last session. Now, let's jump to low back pain. In low back pain, I have quoted a 15-year follow-up study. 60,000 patients have been followed up for a period of 15 years who are suffering from low back pain. You know what is the conclusion they have given? They are having 1.5 times more risk of developing TMD than normal individuals. So we will definitely have to ask the patients the history of all these things. We have to remember, unfortunately, almost all the patients think that the dentist need not be given information about the medical condition. So unless you ask them, they are not going to open their mouth. They are not going to open their mouth. You will have to get into the habits. Most of them will ask, but majority of them, especially the newcomers, they have totally stopped the habit of taking history. Medical history is very, very important. My dear friends, very, very important. See, I have seen dentists suffering because of this. I will tell you 1 or 2 episodes. They have not asked, patient has not told. Patient is on biphosphonates, that extraction socket will never heal. Every day patient will come and sit in your clinic. What have you done to me? These kind of things will happen if you don't take proper history. So identification and referral is very, very important in TMDs. Next disease, irritable bowel syndrome. TMD patients are at greater risk of developing irritable bowel syndrome compared to controls. Do you know what is irritable bowel syndrome? Not inflammatory bowel disease, irritable bowel syndrome. It is called as spastic colon. It is called as irritable colon. You know what patient suffers from? He will have frequently constipation, diarrhea, unexpected. All of a sudden diarrhea will start, all of a sudden constipation will start, and cramps and bloating. Very, very severe. You will see some people telling about this or complaining. You should say, I can't eat anything. Whatever I eat, I have bloating, I have cramps, diarrhea starts off. Whatever I consume, diarrhea starts off. Some patients give typical history. It's very, very irritating. You feel very poor for the very, very unhappy for these patients, you know. And it has been shown by research that TMD patients are at a greater risk of developing IBS when compared to controls. And another thing is, irritable bowel syndrome is present in more severe forms in TMD than in normal individuals. So, again, irritable bowel syndrome is debated. And the universal consensus agrees that definitely psychological factors play an important role in irritable bowel syndrome. So what the gastroenterologists conclude is, for a complete evaluation of TMD patient, it is crucial for us to perform access to diagnosis. That means a psychological evaluation is a must in all TMD patients. And they have also told that co-occurrence of psychiatric disorder, irritable bowel syndrome, temporomandibular disorders is normally seen with a female preponderance. This is what studies are telling. The next disease, chronic syndrome. Different kinds of disorders we are getting to see because of this. You know what is chronic fatigue syndrome? Chronic syndrome is known as myalgic encephalopathy. It is also called as systemic exertion intolerance disease. See the name, systemic exertion intolerance disease. You know what is the meaning of this? I'll give you an example. A person suffering from this disease, if he does a physical activity for 1 hour, he will feel like sleeping for the entire day. That is the problem with these patients. That is the problem with these patients. It cannot be explained with any underlying medical condition. Then apart from these particular symptoms, they also have other kinds of symptoms. They will have enlarged lymph nodes. They will have unexplained joint pains, headaches, unfreshened sleep. When they wake up, they are not. They will have psychic moans, so on and so forth. It's a plethora of symptoms again in chronic fatigue syndrome. They say it is centrally mediated syndrome with no cause. Now, what they have observed here, what is it? Why is it important for us? Now, look at this. If we have patients in this study, what seen is brain activity related to activation of ANS in patients with chronic fatigue syndrome who also have TMD was greater than in patients who screen negative. Please understand, there are 2 groups of patients. Both are suffering from chronic syndrome. In one group, they are also suffering from temporomandibular disorders. In this group, what they have found out is there is increase in the brain activity, which is related to activation of autonomous nervous system. I think it is enough to show that pain is getting modulated. And if you are not managing both the condition, we are going to get into this. With all these kind of conditions coming into picture, the terminology is also changing now. Previously, they used to say comorbid conditions. Then they started calling them chronic widespread pain. Now the National Institute of Health USA, it has given a terminology for this group of disorders, and it calls them chronic overlapping pain conditions. See, the terminology is changing because we are repeatedly seeing all these kind of patients with comorbidities. So, then what I would like to say is knowledge of these comorbidities is very, very important. It is very, very important. And the first thing that will change in the way the approach to our patients is history taking. History taking. All these days, we were just asking them about pain, opening, closing the mouth, biting hard substances, soft substances, maximum neck pain to a certain extent. Remember, now we have changed. You will ask about headache. I'm just giving an example. You will ask about headache. You will ask about neck pain. You will ask about bowel movements. You will ask about sweating. You will ask about exertion. You will ask about photophobia, phonophobia, visual aura, nausea, vomiting, headache, unilateral, bilateral. See the way we have changed and evolved. If you know all these conditions, you will just start asking these questions to the patients, and then you will be able to identify these problems. Your medical colleagues are always there to help you. Don't worry, you need not diagnose these problems. But at least if you identify a particular symptom complex, then it will change the way you look at these patients. I think at least in chronic patients, you should start doing this. If somebody says, I don't have time for this, at least in chronic patients. And another important thing, there are some people, some practitioners who say that who will do all these things, who has to sit and listen to all this blah, blah. And moreover, it is not lucrative. What are we going to earn from this? No, see, practitioner also sitting and listening to this. That's why I'll have to talk. Don't think of lucrative and non-lucrative. My dear friends, if you are able to identify one such patient with these kind of problems and successfully treat, take it from me, he will bring 10 dental patients to you. So definitely it is lucrative. Don't think that managing these problems are non-lucrative. People argue with me. What are you going to get? Maximum you will give one splint, that's all. Because we are used to putting implants, doing bridges, things and like that. See, I'm not trying to criticize anybody, but I'm just trying to tell you the importance of treating these kind of patients. So finally, what I would like to say is identification of these problems is very, very important. Once you identify these problems, you will have to refer it to the concerned specialist, and then you have to co-manage the patients. Now, regarding management, what needs to be done pharmacologically, what modifications we will have to do, we will talk about that in the last lecture. To conclude, I would like to say that one pain condition at baseline, one pain condition, it can be anything that I have shown in the spectrum, all the diseases surrounding that central sensitization. If one pain is present, one condition is present, there is a fourfold increased risk of TMD. Remember this. So you have to increase, the awareness has to be increased, and only you can effectively manage these kind of patients. The problem is, I'm repeating again, the TMD symptoms are often treated with a very, very narrow dental paradigm, while clinicians ignore coexisting pain conditions. So don't ignore these conditions, keep them in mind, and please ask, take proper history, do proper examination, then only we can handle these patients in a proper manner. Thank you for your patient listening.
Thank you, sir, for the elaborate lecture on comorbidities and temporomandibular disorders. Sir, you can continue with your third lecture, sir.
Can we have a 2-3 minute break?
Yes, sir. Yes, sir. So
okay.
You can join in, sir. We are here.
Okay. Okay.
Yes, sir. Yes, sir. The participant can post your questions in the chat box. We are also forming a WhatsApp group for the preliminary round winners for the quiz. So we'll be sending you the details in the WhatsApp also. If you have not joined in the WhatsApp group of the winners of the preliminary group, can contact the registration counter. The numbers are also in the WhatsApp. The next lecture is on the clinical features in imaging. So over to you, sir.
Yeah, thank you.
Yes, sir.
Are you able to see the screen? Are you able to see the screen, madam?
No, no, sir. No, sir. Yes, sir. We are able to see, sir.
Yeah. So we come to the the third part of the lecture, clinical features and imaging. Now, the second part of this lecture, imaging, is a little bit elaborate. because I have added that for oral medicine postgraduate students. Elaborate means I am not going to take more time. I am definitely going to end the lecture in 40-45 minutes. Only thing is, the undergraduate students might find it little difficult to understand, but whatever it is, I will try my level best to make you people understand the imaging. So let's start the clinical features. Now, look at the age prevalence. They say it is predominantly affecting women and they are more prevalent between ages 20 and 40. But again, in terms of arthrogenous and myogenous things, it varies. How it varies? It varies across studies. Number one, patients less than 25 years, the prevalence is more with displacements. Patients in the ages between 55 and 65, displacements with degenerative joints is more. And younger patients experience less pain than older patients. This is about age and TMD based on longitudinal studies. Now, majority of the studies, they say females are getting more affected in terms of TMD. The reason is, number one, of course, epidemiological studies are showing that females are getting affected more. Some people have demonstrated there is something called as cyclical TMD. Perimenstrually, because of hormonal imbalance, the females experience more symptoms of TMD. This is one reason. And of course, there are molecular studies correlating estrogen stimulating the pro-inflammatory cytokines, expression of these cytokines in the synovial fluid, blah, blah. At a clinical level, let us not bother about that. But you should know what is it. Of course, some studies disagree also. Some people postulate that males typically have longer and wider and thicker upper jaws. Males have longer, thicker and wider upper jaws in contrast to females. So the masticatory system can take up the adverse loading in a better manner than in compared to females. That is what some investigators feel. Some investigators feel that in all the stress-related disorders and all the longitudinal studies where prevalence of stress is seen, women are having more predilection for stress and stressful diseases. That is why in TMD also females are getting more stress. And the last concept is that if you look at the arthritides, the rheumatoid arthritis, ankylosing spondylitis, the psoriatic arthritis, seronegative arthritis, in all these diseases, again, there is an increased female preponderance. That is why they are also linking that to TM joint arthritis, and they are telling females have got increased preponderance. That is the reason for this. Next, coming to pain. This is an interesting thing. As I told you, pain can be unilateral, it can be bilateral, it can be in and around the ears, it can be on the joint, it can be in the musculature, it can be in the face, it can be in the temples, it can be on the neck on one or both sides, it can be associated with jaw deviation and sounds. I told you we will not be going into the details of DC or RDC TMD. We will just try and understand the basic clinical features of the temporomandibular joint disorders. The basic things. So I have put this. Disc displacement with reduction. What is disc displacement with reduction? Pain precipitated by joint movement, reproducible joint noise, no restriction in mandibular movement. So when you are putting the joint to action, there is a pain. There is a joint noise while opening as well as while closing, but there is no restriction in the mandibular movement. I've got an excellent video to demonstrate this. I'll show that to you. This is disc displacement with reduction. In disc displacement without reduction, pain is again precipitated by function. There is limited mouth opening. Here you will see deflection of the jaw, not deviation. Deviation means it deviates and then comes back to midline. You will see deflection. Uncorrected deviation to the affected side, that is called deflection. And marked limited lateral protrusion to contralateral side. If pathology is on the right side, patient cannot move it to the left side. They marked limited lateral protrusion. Then we have our, of course, myofascial pain, regional dull pain, localized tenderness. You all know this. Myositis, protective muscle splinting, focal myalgia, your myofascial pain. We all know about this. The difficulty is in understanding the derangements. See, there's an excellent video posted by Mr. Westerson. There's a YouTube link also. That is where I'm playing it from. You can just see this. This is a cadaveric joint. Now you are seeing the condyle here. This is the temporal bone, the glenoid fossa, and you can see the beautiful biconcave shaped disc here, right? Condyle, the disc, and the temporal part, the temporal bone, the glenoid fossa. And here you are seeing the retrodiscal tissue and the lateral pterygoid muscle here. Look at this video. Beautifully, you can see the movement of the temporomandibular joint. Look at this. Rotation and translation. Disc is moving all along the joint when the movements are being done. Superior, inferior, retrodiscal lamina, retrodiscal tissue, disc, central zone, the intermediate zone, posterior band, anterior band. Beautifully, the disc is performing movements. This is how the joint moves. Look at the position of the disc. Exactly lies between both the bony structures. Intermediate zone lies there. Now let's see what happens in disc displacement with reduction. See, the disc can get displaced in any direction. The most commonest direction in which it can get displaced is anterior or anteromedial. So I am just showing you anterior disc displacement. See here, the disc is already displaced here. It is in front of the condyle. When it is at rest position in the glenoid fossa. When the patient is trying to open the mouth, now the disc escapes and slips, and it comes above the condyle. That is where you get to listen to a click. And again, when the patient is putting the condyle back to the glenoid fossa, there is a reciprocal click. You see the video, you will understand. Now here what you are seeing, this is the condyle. You can see that the disc has already slipped into the anterior direction. This is anterior disc displacement. And look at the morphology of the disc. The disc has become rounded. The biconcavity of the disc is already lost here. Look at this. Very beautiful video. See? Yes, this is where you are getting the click. You just see, it will get reduced here. Yes, this is the click. And again, when it is coming back, a reciprocal click. This is jaw deviation which coincides with a click in this particular patient. See, completely anterior derangement. The disc is reduced. Finally, it is coming in between the bony parts, and the patient is able to open the mouth completely. Disc is able to reduce, promoting the movement of the condyle, permitting full opening. This is disc displacement with reduction. There is something called as disc displacement without reduction. The disc will not reduce. It will stay in the same position and it will create a lock. Patient will not be able to open the mouth. Let's see what happens here. See, already the disc is present here anteriorly and it is not allowing the condyle to move. There is a lock. This is disc displacement without reduction. Disc displacement without reduction. Very beautifully demonstrated in this video, is it not? Disc displacement without reduction. So here in disc displacement without reduction, you will see that there is a lock. No, patient cannot open his mouth to the fullest of its extent. Pain on function. Then deflection. In disc displacement with reduction, you are seeing that even though there is deviation, it comes back to the midline because the disc is getting reduced. Disc is getting reduced. Now there are some new oral symptoms. See, I will tell you in my experience, majority of the referrals from ENT comes because of this. Patient will have a fluid sensation in the ear, or a stuffed cotton sensation, or hyperacusis, loud noise sensitivity, cold air or wind sensitivity, or sometimes tinnitus. Now patient will go to the ENT specialist. He will do a thorough examination, do all kinds of tests. If he wants, he will do audiometry, CT of the vestibular apparatus, everything. Finally, he says everything is normal. But he will not tell the patient, you might be suffering from temporomandibular disorder, please go. Unfortunately, he will also tell, there is no problem with the ears, you must be having an impacted teeth. Please go to the dentist. That is how we end up getting these kind of patients. So please be aware that these can be symptoms of TMD. This can be definitely be symptoms of TMD, and it is very, very widely demonstrated. And these symptoms were first published by the ENT people, not our people. Now coming to the examination, what are you supposed to look for? Gait, balance, just to exclude the CNS disorders and middle ear problems. Then unusual habits. See, this is what we are specialized in. When you are having an eye-to-eye contact with the patient, when you are conversing, the quality of communication and the unusual habits that the patient expresses, definitely at this particular juncture itself, you should get a doubt that the patient is suffering from psychological disturbances. Very, very important. Very, very important. Next is a specific TMJ observation. You all know this. Mouth opening. The mouth opening on an average should be around 35 to 50 millimeters based on various studies. And the lateral and protrusive movements should be around 8 to 10 millimeters based on various studies. Then what are you supposed to see in inspection? Facial asymmetry, swelling, masseter and temporal muscle hypertrophy, very, very important. You need to look for this. Then the pattern in which the patient is opening, corrected or uncorrected deviation. Are there any uncoordinated movements? Are there any limitations? You will have to see. These are the things which you have to observe while inspection. Deviation, deflection, swelling, all these things. Then you'll have to look for mandibular range of motion. Look at the vertical jaw movements. Is there a pain-free opening? Is the patient opening to the maximum without pain or with pain? Or is there an assisted opening? You'll have to look for this. Look for horizontal jaw movements, lateral movements, protrusive movements, pain provocation, location, and replication are assessed with each movement. All these movements you'll have to observe. Then you'll have to look for noises. Then you'll have to palpate. Palpation again, you have to palpate for the muscles and palpate for the joint. You are palpating here, place your finger on the condyle. Look for the movements, look for tenderness. There are some rare patients where patients are suffering from retrodiscitis and capsulitis and things like that. In these kind of patients, what you will see is, you will see little tenderness in little posterior aspect, somewhere near to the tragus of the ear and the posterior aspect of the condyle. So you'll have to palpate the condyles. Then the temporalis. Temporalis must be palpated at two places. One is at the temple. Second is where the tendon is getting inserted in the coronoid. For that, you will have to do an intraoral palpation. Again, I want to share my experience here. All the patients that we see here in Bangalore, what we see is this is the commonest place where most of the patients are experiencing tenderness. The temporalis at the coronoid. The data is again anecdotal. The next, palpation of masseter, palpation of medial pterygoids, palpation of digastric. And we all know that the lateral pterygoid is not accessible for digital palpation. So you will have to stimulate the muscle. Under resistance, you ask the patient to perform these movements. Protrusion, retrusion, opening the mouth, and then lateral movements. Or you can take a tongue blade and then ask the patient to bite on that bilaterally. That will show you if the lateral pterygoid is involved. Now, most important is assessment of shoulder symmetry. Movements of the neck, very, very simple. Extension, flexion, and rotation. 3 movements you will have to check for neck. You will get to learn this. It's there in books. It is there on YouTube videos. It is very, very simple. Upward, downward, bending, and lateral bending of the neck. Neck extension, neck flexion examination. Very, very important in assessment of TMD. Shoulder symmetry, movements of neck, rotatory movements of head. Check whether there is tenderness. Try to palpate the neck muscles, at least the sternomastoid and the trapezius. Then there are a lot of provocation tests indicated in the textbooks. I find it is very difficult to give an explanation because theoretically, it is very, very difficult if you start talking about this. I can tell you one simple test. You take 2 cotton rolls. Let us assume one patient is having unilateral pain. Assume that a patient is having unilateral pain. If you ask the patient to bite on these 2 cotton rolls, when the patient bites on the cotton rolls, If the patient's pain increases, it is myogenous because the muscle is getting contracted, right? If the patient's pain decreases, it is arthrogenous TMD because there is inflammation inside the joint. When you bite on the ipsilateral side, on the cotton rolls, the condyle disoccludes to a certain extent, thereby relieving the inflammation there. So if pain is reduced on biting to cotton rolls, it's more often it is an arthrogenous thing. If pain increases, it is a myogenous thing. There is lack of any published sensitivity and specificity for this particular test, but it is very, very simple and useful. I have not learned it. It is there in Burkett. I'm just trying to tell you with that reference. It is a very, very useful test. Burkett is a practitioner's textbook. That is why it is my favorite. Behavioral assessment. When should you do behavioral assessment in patients suffering from TMD? Continuously, if pain is persisting and it is not responding to usual treatments, please think of behavioral assessment. When you are clinically interviewing the patient, if you feel that the patient is suffering from a psychological distress, please get an assessment done. And excessive or inappropriate use of healthcare services. These are classical that we see in corporate hospitals. When they come with a big file. You would have spent 3 lakh rupees. Functional MRI scan, CT scan, audiometry, sleep study, go to pulmonologist, go to pain specialist, physician, neurologist, chiropractor. They would have seen n number of patients. Finally, they will end up. This is what will happen. They would have spent lakhs of rupees. They would have gone to so many centers. They would have got allergy testing done, a lot of blood investigations, serum studies, cancer investigations, a lot of phobias. So excessive or inappropriate use of healthcare services. The moment you see a big file, there itself you'll have to take a decision that this patient is having a psychological problem that needs to be handled. Otherwise, my TMD is not going to disappear. Then excessive use of medication for pain. People are in the habit of doing this. For everything, they want to take pain. Or there are some patients who take alcohol for pain. So you will have to identify all these kind of patients and send them for behavioral assessment. Refer them to psychiatry. For the interest of the people who want to make an assessment on their own, there is something called general health questionnaire. You can use that. See, it is very difficult for us. See, theoretically, if you talk, we can talk about questionnaires. Mood, anxiety, depression scale. Minnesota multiphasic personality inventory. Have you ever thought what is Minnesota multiphasic personality inventory? It contains 600 questions. Do you think patients in India, you will be able to interpret those 600 English questions and ask the patient these questions? It is impossible. The beauty of general health questionnaire is 28 questions available in 9 Indian languages. Thanks to NIMANS, National Institute of Mental Health and Neurosciences, Bangalore, they have done the translation into 9 languages. If you want, you can contact somebody in NIMANS and get this general health questionnaire. We are not doing all these things because psychiatry department is there. We are directly referring the patient to get an evaluation done. But behavioral assessment, very, very important. Again, I am emphasizing this point. In the beginning of the first lecture, I told you, the only treatment predictor that is there in our literature is psychological prediction. The psychological factors, treatment predictor. That is why behavioral assessment is very, very important. Of course, intraoral examination can be done, hard tissue, soft tissue, just to look for wear facets and signs of bruxism. And with this, we end up the examination and we will go into imaging of temporomandibular joint. There are various techniques that are available for imaging of temporomandibular joint. Arthrography, which was very, very famous decades ago. Magnetic resonance imaging. That is, of course, to look at the soft parts. To look at the hard parts, conventional radiographs, CBCT, computed tomography. Last but not the least, you also have USG and scintigraphy. Thermography is also used in so many articles just to demonstrate the effects of treatment before and after. They say thermography, you can see that the hotspot has decreased in size and the treatment is improving. But by and large, what I would like to say is you will have to come out of that particular dental paradigm of taking routinely OPGs for TMD. I will come to it later. Before talking about imaging of TMD, I want all of you to know this. Diagnostic imaging has not proven to be a valuable test for directing treatment, predicting treatment outcome, and determining long-term prognosis. Please note this point. I am not telling this. Burkett's Oral Medicine is telling this. Please make a note of this point. But then what imaging should we do, when we should do? I will tell you that. We'll come to it later. But first, see some facts about imaging. Panoramic radiography, yes. Whenever we go for consultations, already the dentist has taken an OPG. He says patient is coming of facial pain or TM joint pain. We have taken an OPG. There is no abnormality. Definitely, you will not see abnormality. You will see only bony changes in OPG. And bony changes are very, very rare. Before that, a lot of soft tissue changes, pain, and other symptoms would have occurred. Patient would have complained of some first-time TM joint pain or a myogenic pain. What will we do taking an OPG? Okay, it is there for a scanning view. We can do that. But what you need to remember is, unless and until there are gross degenerative and traumatic changes, it will not be evident in an OPG. It will give very limited information. OPG will give us very, very limited information. All of you, please remember this mnemonic MUD, MUD. Very important for OPG. You know what MUD stands for? It stands for magnification, unsharpness, distortion. Please remember this. Three major disadvantages of OPG. You will see magnified images, you will see unsharp images, you will see distorted images. So it is of no use. In fact, you can ask for a TM joint view in the existing OPG machine, or you can straight away ask for a CBCT. If at all you want to see the condyle in a proper manner. Otherwise, it is used as far as TM joint is concerned, it can be used for seeing fractures. In fractures, what you see is almost 60% of the fractures, what you see is fragment angulation and displacement, as you are seeing here. See, here also you are seeing a fracture with medial displacement of condyle. But it has a limited role to play in TMD. It has a role to play only if there are gross osseous changes. So if you suspect osseous changes, if you want to look at fractures of the TM joint, if you want to see intra-articular calcifications, craniofacial malformations which are affecting the TM joint, then CT scan or CBCT can be done. These are gold standards for evaluating these changes. I'll show you examples. See, you can see a coronally reconstructed image, axial multisection CT scan. What you're seeing here, you're seeing a zygomatic fracture here, a vertical condylar fracture here, a displaced fracture here. So that is all is the use of CT and CBCT here. Ultrasound. In most of the Western countries, ultrasound is widely used for TM joint patients. You know why? These people are doing a lot of interventional procedures. Injection of Botox, injection of hyaluronic, injection of steroid, which is very, very commonly seen in some countries. So exactly to insert the needle into the upper or lower joint space, they are using ultrasound as a guiding tool. In some other countries, what they are doing is, before sending the patient to MRI, they are doing a preliminary evaluation with ultrasound, and then only they are sending patients for MRI. So in temporomandibular dysfunction imaging, there are few points that you will have to remember. Number one, most frequent cause of dysfunction as per radiology studies is an internal derangement, right? What is a derangement? It is an orthopedic term implying for a mechanical fault, that interference in the smooth action of a joint. You have seen the smooth action of a joint. You have seen an interfering joint action in the videos. And as I told you, most common internal derangement is disc displacement. It is disc displacement. Again, I am emphasizing imaging should only be performed in TMD patients after a thorough physical examination that indicates the need for more information of the joint status. What is that? We'll talk about it later. Next. MRI is the best imaging modality. MRI is the best imaging modality. The diagnostic accuracy of MRI on fresh autopsy material using oblique sagittal scans, they have found that in determining the disc position and status of the bone, MRI has shown the accuracy of 95 to 93%. Imagine this. So MRI definitely is a gold standard. It is a gold standard. Then depiction of the normal anatomy of TMJ, it benefits significantly when investigating the joint in a 3T machine. I will tell you what is this. 3T stands for 3 Tesla. Tesla is the capacity of the magnet present in an MRI machine. If you go out to diagnostic centers and see, you will come to know that there are centers which are having 1.5T machine and 3T machine. If you want to look at the temporomandibular joint with a good spatial resolution, you need to take a scan in 3T machine. More is the Tesla, more is the spatial resolution of the TMJ. That is why if you want to perform an MRI for a TMD patient, please select a center which has got a 3 Tesla machine. Number one. Several MRI studies have demonstrated that disc displacement is seen in about 1/3 of volunteers with no symptoms. And 90% of them have showed partial displacement with closed mouth, routinely reducing to normal with mouth opening. And only a few individuals have a displaced disc that does not normalize on mouth opening. Again, this is to emphasize that even if you do imaging, you are not going to get a greater information. This is what you will get to see when you do imaging. And 80% of the times when patients are referred for imaging, the diagnosis will be disc displacement. 80% of the times. Since this is so much fulminant, in the year 2006, the Radiological Society of North America, the RSNA, they came out with MR imaging signs of TMJ function. We have to know this. I will tell you why. There has to be a guideline. There has to be a protocol. If you are sending a patient for an MRI of TMJ, who is going to report it? What is the protocol that they are following to acquire the images, and what is the format for reporting? For that, there has to be a reference and guideline. I'm telling you, this is the gold standard. RSNA is the gold standard for any imaging modality, any interpretation in the human body. Take it from me. So in 2006, they established the MR imaging signs of temporomandibular dysfunction. So now we will see how it appears and what are the signs. Before that, again, we will brush through the anatomy once. Condyle, glenoid fossa, eminence, lateral pterygoid muscle, superior and inferior, retrodisc lamina, superior and inferior, biconcave shaped disc, superior joint cavity, inferior joint cavity, and then the retrodiscal tissue here. Same thing you will see. T1 weighted magnetic resonance imaging. You are seeing the condyle and the disc. See, again, different things appear in a different manner in different sequences in MRI. I am just trying to show you the sequences. One or two examples. Look at this. This is a sagittal scan, sagittal MRI scan. You can see that the disc is beautifully depicted here. You can see the thin intermediate zone, thick posterior zone, thick posterior zone. And what are you seeing here? In the same patient, when the patient is in a closed mouth position, you are not able to see the retrodiscal tissue at all. But if the same patient is opening the mouth, you can see the disc and also the retrodiscal tissue here. So oblique sagittal scans are very, very important when you are looking for a particular acquisition in MRI. Now, the clinical signs that we have to talk about is the first step in assessing the temporomandibular joint is precise localization disc. It is very, very important. What are the things that you have to look for in the disc? First, you will have to check the morphology of the disc, whether the disc is crumpled, rounded, flat, or perforated. You can see this. This is a normal disc. This is a normal disc. In this particular section, what you are seeing is there is a flattening of the condyle and crumpling of the disc. Right? Here the disc has become rounded. Here the disc has become rounded. And here it is displaced again. And what has happened here? There is a perforation. If you see, there is no continuity of the disc here. There is a perforated disc. So unless you do it, you take a 3D MRI and acquire images, you can't see such beautiful images of the disc and the condyle. So you can see crumpling, rounding, perforation, so on and so forth, and flattening of the disc. Next is abnormal disc displacement in closed mouth position. Now we are telling derangement. or displacement. But what is the guideline for that? There has to be some guideline, no, with which we can see and tell that the disc is displaced. So there is a guideline. Imagine this is the long axis of the condyle. Long axis of the condyle. Now this is the disc. This is the posterior attachment, the posterior band, what we call as the posterior band. Now the guideline says if the posterior band lies between 10 to 30 degrees of the long axis of the condyle, it is normal. If the posterior band lies in between 10 to 30 degrees of the long axis of the condyle, that is the 12 o'clock position of the condyle, it is normal. If it extends beyond 30 degrees, it is displacement. Some people believe more than 10 degrees itself is partial displacement. Some people say more than 30 degrees itself has to be given as displacement. So you are seeing here, this is the long axis of this is the condyle. Long axis of the condyle, you can see the posterior attachment here. It is around 45 degrees, pakka displacement. So this is the guideline for displacement. See this, partial anterior displacement at baseline. Posterior attachment, you see, imagine this is the long axis of the condyle. It is still around 15 to 20 degrees, only partial displacement. But when you take a look at this, long axis of the condyle, posterior attachment. See this, posterior attachment, long axis of the condyle. Posterior attachment, long axis of the condyle. Definitely more than 30 degrees. You can straightforward give it as disc displacement. Disc displacement in the lateral direction. Disc displacement in the medial direction. Some more examples. Look at the spatial resolution here. Beautiful. Nobody can miss this. Now, abnormal disc movement in open mouth position. What you are seeing here? You are seeing there is a displaced disc. There is a displaced disc. And there is disc displacement without reduction and with reduction. See here, the disc is coming in between condyle and the bone when the patient is opening. Anteriorly displaced disc. Same patient, when he opens the mouth, disc is in between the bones. Here what is happening? Disc stays here. You look at the morphology of the disc, the same crumpled disc which we saw, the other image. All these images are from the same article, MR Imaging Signs of Temporomandibular Dysfunction. You can search for that article, you will get complete information. And you will also get to see other images also, which are beautifully given. Now next, osteoarthritic changes. How do they appear in the MRI? What is this? What are you seeing here? You are seeing a small condylar erosion here. Here you are seeing a bright signal. This bright signal is a sclerosis. You are also seeing a shape in the change in the shape of the condyle here. This is an osteophyte. What are you seeing here? Flattening of the condyle. Again, you are seeing an osteophyte here. So these are the osteoarthritic changes that you will get to see. Now there is something called as joint effusion. Clinically, except for pain and function and pain in the posterior aspect of the condyle while palpation, you will not get to see anything else to give it as joint effusion. You have to do an MRI to say that it is joint effusion. It is best depicted in T2-weighted sequence. What they have told is joint effusion is an unusual sign in asymptomatic individuals. Most of the times it is seen only in symptomatic patients. And what they have depicted is, if you see joint effusion, it is strongly associated with displacement and it represents an early change that can precede osteoarthritic change. This is how joint effusion appears. It gives as a very, very bright signal, very, very bright MR signal you are seeing. This is the joint effusion. Now, retrodiscal rear rupture. Retrodiscal rear rupture is also a very, very rare phenomenon. Now, improvements in MR imaging, we can get to see all these things. You see this. This is the retrodiscal layer here, beautifully seen. Again, patient is partially opened the mouth. You can see that the retrodiscal layer is ruptured here in this particular patient. And there are some indirect signs. They say there is an increase in the lateral pterygoid attachment in few patients. Of course, there are not a lot of supporting studies on this. More or less, the direct signs are important for us. So to summarize, what are the signs? anatomy of the disc, morphology of the disc, position of the disc, displacement of the disc, abnormal disc movement in open and closed mouth positions, then osteoarthritic changes of the condyle. These are the MR imaging signs of temporomandibular dysfunction given by the Radiological Society of North America. This is a dictum. This is what we are supposed to follow. See, what I am trying to tell you is imaging is necessary to supplement clinical diagnosis. When imaging is considered, it should be considered when your conservative treatment fails, when there is history of trauma, and if you see sudden change or significant change in the occlusion, you will have to go for imaging. And let me tell you, asymptomatic click, please don't send them for imaging. Don't treat them also. There is no need of treating a patient for joint sounds. To summarize again, it is not necessary for all of us to know all these things. If you don't know how to interpret an image, not a problem. The radiologist will interpret and give us the report. From our side, what we have to do is, we have to identify a center where 3T machine is available, number one. Number two, most of the radiologists are used to do the spine protocol for TMJ and give us the report. Don't think that those people will not listen to us. We cannot discuss the protocol. No, those days have gone. Everything is practice driven. If you speak to the radiologist, he will be extremely obliged. He will agree to this. If he does not have this, you give them the reference article and you tell them, sir, please give us the report based on this article. He will agree and he will report it on the same way. For them, it is like peanuts, seeing that article and doing the reporting on this in this particular manner. Only thing is, they would have not got used to doing reporting in this manner. Some people follow, some people don't follow, but definitely you can discuss the protocol with the radiologist and get it done. Some people feel it is very, very important to do a CT scan if any osseous changes are seen in the condyle, because MR sensitivity and specificity in detecting flattening, erosions of condyle is not good. Yes, you can ask for a complementary CT. Most of the diagnostic centers, if they do an MRI for TMJ, if they find out a bony change, they will not charge for CT. It is not only for TMJ, it is a protocol for any other joints. If they have to do a complementary CT, they will not charge for it. You speak to the radiologist, he will do this for you. So in my experience, chronic patients, we are doing imaging. If I plan to give an anterior repositioning splint, I will definitely like to confirm that there is anterior disc displacement with MRI, because you know the kind of corporate clients we get. Without demonstrating, if I directly give anterior repositioning splint, if something happens here and there, he'll come and sit on our heads. So documentation, all these things are very, very important. Patient would have done significant research on the internet before coming to us. That is the problem in treating these kind of patients. And I personally feel if you do an MRI, you can counsel the patients better. That cognitive awareness of disc displacements or disc displacement without or with reduction, you can demonstrate to the patient on the films. He will be cognitively better aware of his problem and he will understand his problem and he will follow the instructions properly. He will wait for the disease to heal. So for patients counseling also, you can use this. It's not a compulsion. I'm just sharing my experience with you. With this, I'm ending this session on clinical features and imaging. Thank you for your patient listening.
Thank you, sir, for the elaborate lecture on the various investigations and the emerging modalities. Now we are into the most awaited part of today's program. It's the final round of the quiz. I would like to invite Professor Dr. N. Mohan, our renowned quiz master, to conduct the quiz. The results of the quiz will be declared towards the end of today's program. And over to you, sir.
Share the screen.
Yes.
Okay. Thank you, Dr. Savita. Am I audible? Okay. First of all, I'd like to thank Dr. Srinivas for the excellent lectures. I found it very useful, simple, and probably easy to follow for everyone. Probably people from undergraduates to specialists and postgraduates, I'm sure, it would have been very, very enlightening. Thank you, Dr. Srinivas. Okay, about the quiz, we've already finished the preliminary round, and after the responses were received, you actually listed out the toppers, and we are getting we got the toppers listed out, and they'll be given the chance to enter the final round. I think the link will be sent as a code, and the code has to be entered in the screen before you can actually become a part of the final round. So the list will be already in the hands of the people. I think the finalists will be getting their code very soon. Okay. So the format is very simple. This will be something which will go online as we move around, and it contains about 15 questions. And all the finalists are requested to log on to quizis.com. Can you see it in your screen? Okay. Yeah. Okay. So just, or you can use the link called joinmyquiz.com, and that can take you to this website in your browser. You don't have to register, you don't have to log in. You just need to join the quiz by giving a code. The code will be sent to you shortly. The final session will be about 20 to 30 minutes. And the most important thing is that as you answer, the first to answer will get more marks. So your quickness also counts. Most of the questions may be simple. Most of them are in the multiple choice format. Some of the questions may require that you type in your answer, which may be a very short answer. And there'll be appearing as soon as most of the participants have finished on the screen. And more points will be given to people answering in a shorter time within the time limit. So most of the questions have a time limit of about 20 to 30 minutes. Please keep that in mind. You have to answer quickly, and within the time limit, if you're answering first, you will be able to get more marks. And the most important rule for the quiz is that my decision will be final, and the network connectivity issues will not be considered for the winners. Okay. So some of the questions will also be from the lectures of today. Maybe most of the questions will be from the lectures given today. Okay, if you're all ready, I'll just give you the code for the current final session. Okay, please go to joinmyquiz.com or quizis.com, and the code is 787846. You need to give the code first, then it will ask you to give your name. Please give your exact name properly so that we can identify the winners. Yeah, we see one person has already joined. So we want all the 100 to join, 99 to be exact, before we start. If there are any issues, you please call the administrator or the registering desk. We already have about 30 participants. This any problem? And the group button about somebody else puts the yeah, please note only the finalists have to join. The list of finalists have already been given. The group, and the link has been sent to the others. Sent to everyone. Hmm? He's there, huh? Let's put it in the chat. Hmm? Yeah. Only the finalist have to go. Tell we'll have to try. Then you have to close it. And yeah, but already அதேதான் வரும். வேற செஷனா மாத்திடலாமா? எடிட் பண்ணி திருப்பி பப்ளிஷ் பண்ணா மாறிடும். Okay, there's a minor technical issue. I think the final round winners, please hold on to your this thing. We'll get another code before you can rejoin again. We'll see if you can restart the session. Okay. Maybe exit. இல்லை இதை ஒரு எடிட் பண்ணிட்டு publish again another code will come. I think the final participants can give the code that is sent to their mobiles or to their emails and rejoin the session. Only the finalists have to join. Yeah, please go to the new WhatsApp group created and see your code and join, please.
Done.
Share screen. Screen வருதா தெரியுமா? நம்பரே தெரியுது. I exited. No, the code number is visible. No, once we start, they can't join.
அப்ப நம்ம அப்புறம் செட் பண்ணிக்கலாம். இந்த விண்டோ மட்டும் பண்ணணும். இந்த ஒரு பேர் வந்தாங்க.
So we'll give you 5 more minutes to join. We limit reach actually. This is the old code. This is the new one. 86. பழைய கோடு போட்டு முதல்ல ஒரு கோட் தப்பா கொடுத்துட்டோம். So we almost have all the participants online. We'll just wait for a few minutes before we start. So the format is the question will appear on the screen once I start sharing my screen. You need to answer in your browser on the screen. It may be multiple choice, in which case you have to select the correct choice, or if it has to be typed in, maybe a 1 or 2 words only, you need to type it in. There will be a total of 15 questions. We'll start 87. Sharing it. 91 is start.
91 is start.
89 of course.
இந்த பையன் மெசேஜ் வருது குரூப்ல
Oh, Anjali.
I think போதும்னு நினைக்கிறேன்.
Yeah. So once we start, others can't join. We are just waiting for the last few. Another minute or so before we start. A few people are sent the same code, no? In the group. 89. think we'll start. Okay.
Sound.
What to do? Sound overlay. Sound is not. Sound overlay. Is it visible? Okay. Somebody join. Okay. Can you start? 90, yeah. Start பண்ணிடலாம். Sound வரல. I think we can start. Two. Sound on that. Yeah, 10 to 15 minutes. Your questions have started. Please answer on the, look at the screen and start answering. Yeah, time is up, or go for the next one. Good, I think almost everyone answered. No, that's all. Okay, thank you very much, all the participants. I'm sure you'll all be eager to know the results. Please hold on as we analyze the results. We'll let you know at the end of the program. I think towards the concluding session, you'll know the winner. Thank you. We really appreciate your active involvement, and some of the answers were very lightning fast. That was really very encouraging. Unfortunately, we couldn't have given you more time, but still many of you actively participated. Thank you very much for that. And thanks for the other participants to patiently observe the proceedings. Thank you. Over to Dr. Sabita.
Thank you, sir. We'll have a short lunch break. For the final session, we request all of you to log in by around 2 o'clock. Welcome back to the last lecture of today's program, which is on the management of temporomandibular disorders. Over to you, sir. Srinivasan, sir. Kindly wait as there are some technical issues.
Yeah, good afternoon. Am I audible?
Yes, sir.
See, you have disabled my screen sharing.
We'll work on it, sir. You're now the host, sir. Please try again, sir.
No. Can you see this?
No, sir, not yet.
I don't think so. Not happening. You want me to log in again?
Yes, sir. Yes, sir. Yes, sir. We are
Me.
able to see, sir. Yes, sir.
Can you hear me?
Yes, sir.
Can you see the screen?
Yes, sir.
Okay, good afternoon, one and all. I feel this is the most difficult task, addressing people post lunch. Anyways, we are in the most interesting part of the presentation as well. Let's see how to manage these treatments. Good afternoon once again. What are the goals of treatment? Please remember, you can't do wonders here. Your first goal is to reduce the pain. Whatever modality you are using, your first goal is to reduce the pain. Your second goal is to improve jaw function. Your third goal is to reduce the tension and parafunction associated with the patient. It has become quite fashionable for people to do functional manipulation. I don't know whether you are aware of it. Functional manipulation is nothing but digitally you hold the mandible and manipulate it so that in disc displacements, it will promote the disc to go back to its position. It is somewhat similar to what we do in a dislocated joint. A lot of people do this functional manipulation. Yes, you can do it, but please don't attempt it in asymptomatic patients. According to me, you should not be treating asymptomatic patients. I am not telling this. Literature with proof is telling this. So restoration of the disc position is of least importance when you are treating patients. What is more important is improvement in jaw function, reduction in pain. Please remember. So when you are talking about management, to revise again, most important things that you'll have to keep it in mind. Are there any comorbidities? Number one. Number two, Recent restorative events to check whether there is any change in the occlusion. Recent restorative events, please underline. It can be a bridge, it can be a filling or whatever. History of bruxism, chewing pattern, psychiatric illnesses. Most important points that you need to think of. This bruxism is a little dicey thing. Sometimes patients will tell, no, I am not doing this. Actually, the patient will not know because he is doing it during deep sleep. So you will have to either ask patient's wife or patient's husband or whomsoever is staying with them. And I personally feel you should give some time to the patient. When he comes first time, you start him on an empirical therapy and ask all the patients to observe. Ask the patient's attenders to observe for a week whether the patient is bruxing or not bruxing. Straight away with one interview, don't decide that patient is not bruxing. This is very, very important point, my dear friends. This you will have to get into practice. You should just not give it up. So please keep it in mind. History taking, you have to keep it in mind, keep comorbidities in mind, recent restorative events, chewing pattern, as I told you in our country, unilateral chewing habit, very, very important. And of course, the psychiatric illnesses. Also keep an eye on perpetuating factors, posture, allergies. See, there are some studies which say that if the patient is suffering from some kind of allergies, and if the patient is suffering from thyroid disease who is not on medication and uncontrolled diabetes, their response to treatment is a little bit altered. So if a patient is suffering from these disorders, make sure he is getting properly treated for these things. Then if psychological problem is present, then it has to be managed in a proper manner. Now let's come to proper management protocol. If the patient comes to you and it is a first episode, the first and foremost thing you'll have to do is advise soft diet. Advise soft diet. Rest to the joint. I still remember when we were undergraduate students, my professor Balaji Rao sir used to tell this. Rest to the joint is best to the joint. Even today it holds good. Rest to the joint is best to the joint. Heat and cold therapy can be given. If there are any recent occlusal changes, please restore it. Now regarding NSAID, first episode, no need to treat the patient with diclofenac, ibuprofen, ketorolac, not required. Start with paracetamol. This is what research says. There are plenty of articles. These articles will give you the algorithmic approach for analgesic prescription in dentistry. Always remember, start with plain paracetamol. Gauge the pain of the patient. You will not require analgesics like ketorol, ibuprofen or diclofenac for these patients. You might require a muscle relaxant. We will talk about that. So give them paracetamol, give them muscle relaxants. And if there is a history of night grinding, bruxism, give them a night guard. A hard night guard, which is basically a polymer, which fits in nicely, should be given to the patients. Hard night guard, please remember. Now, most of the recent big time labs are doing wonderful night guards. Give them this hard night guards, number one. Now, another important thing that you will have to tell these patients is, if the patient is having unilateral chewing, see, prescription, give them a printout. That is all you need to do. Or you can retype if you want. Please give them an instruction sheet. So this is all you need to do in the first appointment. In the first episode of pain, I'm sorry, predominantly myogynous, it is self-limiting. What you have to do, soft diet, rest to the joint, occlusion restored, paracetamol, muscle relaxants, night guard for bruxers. How much paracetamol you can give? See, paracetamol is wonder drug. You can give it for pregnant patients, you can give it for heart failure patients, you can give for transplant patients, renal patients, liver, anybody, not liver patients. Anybody, you can, most of the patients, you can give paracetamol very, very safely, including pregnancy and lactation. You can, in adult patients weighing around 60 to 70 kilos, you can go up till 4 grams per day. Even though in India, we don't prescribe so much, 650 milligrams can be given 6th hourly also. So you can start the patient on paracetamol, and muscle relaxants, I'll talk about it. A separate slide for that. Habit reversal instructions, very, very important. whether the habit is bruxing or the habit is tongue thrusting or lip biting or nail biting, whatever it is, habit reversal instructions are very, very important. Please instruct the patients to keep their teeth apart. How can they keep their teeth apart? Tongue can be kept in the floor of the mouth. Alternatively, tongue can be kept in the palate. The tip of the tongue can come in contact with the palatal surfaces of the upper central incisors, and then the patient can be asked to close the mouth. All these things, this written form of these instructions are given in Burkett. You can just take a printout of that. Or if you have not seen, please open Burkett and see it. Neutral head posture they have to maintain. Bilateral chewing, very, very important. Now I would like to share my experience here. This unilateral chewing causing adverse loading is very, very important. Now, majority of the patients who have got into the habit of unilateral chewing for some or the other reason, they will continue to do so. Or once the pain comes down, again they will get into unilateral chewing. They will forget the doctor and the doctor's instructions. So what I ask them to do is, the places where they are sitting and eating, I'll ask them to put a sticker or wear a band or something that would remind them of eating both the sides. Because if they continue that habit, this particular thing keeps coming again and again. For that reason, I ask them to do this. So habit reversal instructions are very, very important if identified. Do not neglect them. So if a patient comes to you with a complaint of this, you examine the patient, establish a diagnosis of myogenic TMD, you give them pharmacotherapy to decrease the inflammation, give them splints to decrease the muscle activity. Additionally, if the pain is not coming down, you can give them physiotherapy, again to decrease the muscle activity and maintain mobility. Alternatively, if your diagnosis is internal derangement, again you will require short-term pharmacotherapy, splints, physiotherapy for decreasing inflammation and maintaining mobility. This particular protocol is keeping in view about all the problems that we have discussed. We have not discussed comorbidities till now. Let's see how to manage those things. Now, what does the Cochrane review says about pharmacological management? About 11 studies were included. Unfortunately, insufficient evidence because there are lack of good RCTs. What I have given you is the best evidence that is available. That we will see in the next slides. Muscle relaxants. There are so many muscle relaxants that are there in the market. Each one has got a different favorite muscle relaxants that they want to use. Somebody wants to use chlorzoxazone, somebody wants to use phenoprobamate, somebody wants to use metaxalone, somebody wants to use thiocolchicoside. But let me tell you, based on the studies, the best muscle relaxants that anybody can give is chlorzoxazone, clonazepam, diazepam, and tizanidine. Tizanidine is a centrally acting muscle relaxant. 2 milligrams once or twice can be given. One thing you will have to keep it in mind when you are prescribing tizanidine, you'll have to be a little cautious in renal and hepatic patients. And secondly, this will cause little hypoaesthesia, tizanidine, and too much of drowsiness. Please keep that in mind. Then when you are prescribing diazepam and clonazepam, prescribing information, disease information, everything needs to be documented because it is a scheduled drug. You know what happens with drug abuse and adverse uses of these drugs. Please keep that in mind before prescribing these medicines. Diazepam and clonazepam. Excellent muscle relaxants. Excellent muscle relaxants. The beauty of diazepam and clonazepam is you can also prescribe in children. If you are thinking of prescribing a muscle relaxants for children, clonazepam and diazepam is the choice. Now coming to chlorzoxazone, widely prescribed by most of us, very good evidence it has got. For all patients who are coming to you initially, you can start the patient on chlorzoxazone. Majority of the brands available in the market are available in combination with diclofenac, paracetamol, and chlorzoxazone. No need to give diclofenac. Don't load the patient's kidneys. Give plain paracetamol and chlorzoxazone. Plain chlorzoxazone tablet is not available in the market. It is available in combination with paracetamol. You can use that. One example that I can say is Myospaz. You can use this combination. So what exactly muscle relaxants do? Very, very simple. They decrease the muscle tone and make the muscles relaxed. So when you are combining an NSAID with muscle relaxant, you are decreasing the inflammation, you are decreasing the muscle tone. Concurrently with your instructions and directions, you are giving rest to the musculature. Automatically the pain will disappear. Anticonvulsants, very, very important medications in treating TMD. Most preferred anticonvulsant in treating TMD is gabapentin and pregabalin. I would say pregabalin is more preferred. Pregabalin is more preferred. How does this act? This pregabalin, it acts, it has got an primary inhibitor in neurotransmitter. This GABA is a neurotransmitter in the brain. So this GABA-like drugs, this pregabalin, what it does is it reduces the neurotransmitter release and thereby decreases nociception. The dosage of gabapentin that you have to start is, gabapentin that you have to start is around 300 milligrams per day. And if it is pregabalin, you can give 75 milligrams per day. I'm telling you, pregabalin is an excellent drug. In contrast to gabapentin, you can choose pregabalin. When should you give pregabalin? Chronic cases of temporomandibular joints.
Sir, your screen sharing has stopped, sir. Your voice is also not audible. So please unmute and speak, sir. Sorry for the inconvenience. There's some technical issues, so we'll get back to us. The feedback link for the entire program would be sent during the vote of thanks. We request all the participants to fill the feedback link to receive your certificates.
Am I audible?
Yes, sir.
I'm sorry, I had a power cut and the router rebooted.
No issues, sir.
So pregabalin should be used when you have a comorbid cervical dysfunction, low back pain, or fibromyalgia syndrome. Now, the cervical dysfunction, fibromyalgia syndrome, and low back pain are managed in the form of different management strategies by other specialists. Sometimes they will be taking only physiotherapy or some stabilization exercises or some other modes of treatment. In those patients, if you see chronic TMD which is not responding, you can start pregabalin. Most important point. If these comorbid conditions are found, you can start pregabalin. 75 milligrams OD. What you'll have to keep it in mind is these are not the medicines that you can use it for a day or two or probably 1 week. Once you start pregabalin, you should give it for a period of 3 months at least. 3 to 6 months is the preferred duration to be treated given for chronic TMD patients. Fantastic drug. Tricyclic antidepressants. Now this, I would say this is the mainstay of our treatment. You know, these tricyclic antidepressants are better than SSRIs in treating depression also. It has been shown by research with solid proof that it is a first-line medication for patients refractory to splint therapy. Please understand this. If you look at the English literature in PubMed, what, to your astonishment, you will find that the most studied medications for temporomandibular disorders are antidepressants and only antidepressants. How does it act? It causes serotonin and noradrenaline reuptake inhibition. TMD patients are shown to have depressive states and lack of sleep also. So it is acting in both the ways. Now there are some problems associated with prescription of these drugs. Let us discuss one by one. But let me tell you, this is a very, very important prescription that you all should start doing. What are the studies telling? Amitriptyline 10 to 25 milligrams per day has got a level 2 evidence. If you check the meta-analysis based on 11 studies, that's a very good scale of evidence. The second line of therapy should be nortriptyline and desipramine. Now, when do you choose this? Generally, by and large, I choose amitriptyline for most of the patients. If the patient somehow has got some cardiac problems, or patient is having some amount of dryness for because of some other problems, I can give you an example. Let us say one Parkinson's disease patient has come with TMD. After taking a consent, or if a patient suffering from SLE has come to you with TMD, already there is dryness associated with SLE. So nortriptyline will be more preferred than amitriptyline because the degree of dryness caused by nortriptyline is lesser in contrast to amitriptyline. Now, when do you choose these drugs? All TMD patients, you can start this medicine, irrespective of whether the patient is having comorbidities or they are not having comorbidities. If the patient is having a psychiatric problem, a psychiatric comorbidity, and he is managing with other techniques like relaxation, yoga, meditation, you can start amitriptyline. If the patient is having stress and other issues managed because of other things, managed by other things, you can start amitriptyline. If the patient is having comorbid migraine, I am telling you, best drug is amitriptyline. Amitriptyline has been shown as the most effective drug used in the treatment of prophylaxis of migraine.
Sir, again, there's a problem, sir. Your voice is not audible. I request the participants to kindly wait as there are some technical issues. So please unmute and speak, sir.
Can you hear me?
Yes, sir.
I'm extremely sorry, ma. Something funny is happening with the generator of the apartment.
No issue, sir.
So we'll come back to this tricyclic antidepressant. As I told you, this is an excellent agent in managing prophylaxis for migraine. It will also act on TMD. It will also act on migraine. You can start the patient on 10 milligrams of amitriptyline. Depending upon the response given to the pain, you can scale up to 25 milligrams per day. You can go up to 25 milligrams per day. But there are certain important things that you need to remember when you are prescribing these drugs. Point number one, all these tricyclic antidepressants are pro-arrhythmogenic drugs. Pro-arrhythmogenic drugs. If you want to prescribe this medicine, it is necessary for you to send the patient to a cardiologist or a physician, get an ECG echo done, check whether the QT interval is prolonged. Unless a cardiologist gives you a consent, you cannot go ahead with the prescription of amitriptyline. Otherwise, it is a relatively safe drug. But this consent is very, very important, number one. Number two, this one is a scheduled drug. It is an antidepressive medication. If a patient gulps about 25 to 30 tablets of amitriptyline, you know what issues can happen. Therefore, documentation is extremely important. See, I will tell you one thing. People give all these kind of things in the books. We know there is evidence, but how many of us are prescribing it? Please think it over. You know what happens? You need guts to prescribe this medicine. It's not a joke. Speaking in a lecture like this is different. Prescribing it for patients is different. Right? Even I didn't have that guts. I am no different from you people. With God's grace, I am in a corporate hospital. That is why my medical colleagues have taught me, trained me, and made me prescribe these drugs. Otherwise, it is very difficult, my dear friends. See, there are a lot of consent forms available. Consent for implants, consent for root canal, consent for flap surgery. There are no consent forms for prescribing these kind of drugs. I went to the extent of going and consulting our medical legal consultant to ask him, what should I write in the consent form if I'm prescribing these drugs? Now what I am doing is, in the regular consent form, I am writing it by hand. You know what I write? Known case of chronic TMD indicated for amitriptyline therapy. Cardiologist has examined and given the consent for prescription. All possible risks of the medication and instructions pertaining to the medication given to the patient. You write this much, take the patient's signature, phone number, everything, and you keep that document with you. This much if you have, I am telling you, nobody can touch you. I am telling it with this confidence because this was told to me by Professor Jogarao, one of the topmost medical legal consultants in India. See, either you have to treat, and if you don't treat, you are not in the market. So somehow I had to get into all these things. So all my medical colleagues helped me do this. So I am telling you, this drug works wonders. Not only for burning, not only for this facial pain, it works for atypical facial pain. It works for burning mouth syndrome. This is my favorite drug. So these things are of paramount importance. ECG echo, cardiologist consent, informed written consent, very, very important. Informed written consent. See, this informed written consent, whatever words I have used, you can use these things for all the drugs that we prescribe. We are prescribing nortriptyline, we are prescribing pregabalin, we are prescribing clonazepam rinse for burning mouth syndrome, we are prescribing skin clobetasol cream for oral cavity. What if something happens? The patient will come back and ask questions to you. You tell him you want the treatment, you believe in me, you sign this. I am not giving you a rare drug. I am not doing a trial on you. I am doing what is documented. Whatever is available in this country for treating your condition, I am doing that. You have to sign a consent. And let me tell you, a lot of people feel that patients will not sign this consent, this and that. No. In my experience, all the patients will agree and they will sign the consent. They are not bothered. If you just go to medical side OPD and see the kind of drugs that they are prescribing, you will go mad. This is nothing. Only thing is that beginning step is important. If you start prescribing these medicines, you will get used to it. Second most important thing that you need to remember when you're prescribing tricyclic antidepressants are the drug will take at least a period of 2 to 3 weeks to start showing some results on the patient. Don't expect dramatic results in a week or two. Start 10 mg, immediately don't jump and start 25 mg. Wait for a month. You wait for a month. Slowly, the drug will take at least a period of 2 weeks to reach the blood levels. Then it will slowly start showing effects. Then when you are prescribing these drugs, you will have to instruct the patient about drowsiness. Ask the patient not to go out alone, not to climb the stairs alone, not to cross the road alone. All these things are of ample importance to us, right? These things are to be followed. How many days it has to be given? It has to be given minimum for a period of 3 to 6 months. And this drug is also associated with some kind of a dependence. So once you see that patient is symptom free for a month or two, then you start tapering the dosage. Taper it down to 10 mg. Then you can probably ask him to take half tablet, slowly make it to alternate days, once in 2 days, and then finally stop the medicine. You don't require any periodic monitoring for these medicines, just like what we do in immunosuppressants like azathioprine or cyclophosphamide or dexamethasone. Once you start the medicine, you take the consent, you can continue the medicine, no problem. But all other things that I have told, it is very important that you'll have to remember this and follow these instructions. Buspiron. What is Buspiron? Buspiron is a very, very important drug for us. If you remember the slide that I showed you in the first lecture, I showed you SSRI induced bruxism.
Sir, again, there's a problem, sir. So please unmute and speak, sir.
Will you hear me?
Yes, sir.
I'm sorry once again, extremely sorry.
No
Please bear with
problem,
me.
sir. No problem, sir.
So I was talking to you about iatrogenic bruxism. Bruxism induced by drugs like paroxetine, fluoxetine, so on and so forth. This is the treatment for that. If you find a patient who is suffering from iatrogenic bruxism, you can start them on Buspiron 5 to 10 milligrams BD for 4 to 5 weeks. Bruxism will automatically stop, and then you can stop this medication as well. Propranolol. The second line of treatment for patients who are comorbid with migraine. Why am I talking so much about migraine? When you start seeing patients, you will know most commonest comorbid disorder. If you see 5 patients, 1 or 2 of them will have migraine. My observation, data might be anecdotal. Try for your own self and see it. In propranolol, you need to understand something. There is something called as the COMT polymorphism. You know what is the COMT polymorphism? This is this catechol-methyltransferase gene. You know what does this gene does for us? This gene, it manages stress. It manages stress. When there is a polymorphism of this gene, what happens is the stress bearing capacity is slightly reduced and a person is more affected for getting these musculoskeletal disorders. If a person is having this COMT polymorphism, they are more prone to get musculoskeletal disorders and also migraine. And if there is a polymorphism of this, then it induces pain via beta-2 adrenergic receptors. Therefore, it has been shown in studies that if you give a beta antagonist in patients who are having COMT polymorphism, it acts as a better analgesic for these patients. So this is a second choice for comorbid migraine. 80 milligrams divided per day in divided doses 4 to 6 weeks. 4 to 6 weeks, it will combat migraine as TMD, also TMD very, very well. Very, very nice drug. Only thing that you have to remember in this prescription is patient has to be evaluated. Patient has to be warned about low BP. You will have to keep that in mind when you are giving this particular medicine to the patient. Now coming to the next important thing, physiotherapy. All patients you can use physiotherapy. All chronic patients or acute patients where the symptoms are lasting for more than a week or 2. What are the modes of physiotherapy that we are seeing? Stretch and muscle relaxation, transcutaneous electrical nerve stimulation, dry needling, low level laser. Let us see what are the studies showing and what exactly needs to be done. There are a group of physiotherapists who are extremely interested in treating TMDs. Yours is a university. I think you need to interact more with physiotherapy department in managing TMD. We have an excellent coordination at our hospital. We co-work together for all TM joint patients. See, it has been shown that Neck motor control and stabilization exercises, if it is done for 5 weeks, there is a significant decrease in TMD pain. I told this to you when I was talking about the cervical muscles, when I was talking about the posture. The physiotherapists are very, very obsessed about something called as Radomed 6x6 exercises. You can find the information of this Radomed 6x6 exercises on the internet. It will also teach you how to tell the patients. It can also teach the patients on how to do Radomed exercises. It has shown very good relief. I was talking about functional manipulation. This is also predominantly done by physiotherapists, but please don't get into this. In my experience, we have seen more aggravation of pain rather than limitation of pain. And secondly, the first principle you remember, asymptomatic derangements you need not treat. You don't worry about the position of the disc. You worry about the function of the joint and reduction in pain. So what is it that we have to do? Dry needling. It is very, 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 very easy. You can also learn and do it. It is better than wet needling. Wet needling is acupuncture. It is definitely effective in reducing pain in myogenous TMD. You can use dry needling. Weekly 2 or 3 sessions you can do for a period of 4 to 5 weeks. It is very, very effective in managing pain. Low level laser therapy. I will have to take some time and talk to you regarding this. Point number 1, low level laser therapy is definitely effective. Diode laser. That these are the machines that we all are owning. Now, unfortunately, what has happened is in the market, the people who are selling this cutting laser, the laser that is used to cut the tissues, that is used for gingivectomy, that is used for frenectomy, that is used for flap surgery, unfortunately, the nanomicrons supplied for this does not match low-level laser therapy. Please remember. No doubt there is an option for healing. There is an option for TMJ pain. There is an option for photodynamic therapy. There is an option for photobiomodulation in these laser machines. Don't believe them. It doesn't work. If you want low-level laser therapy to work, please buy a machine where the frequency range is around 780 nanomicrons. That is the preferred frequency range for a laser machine if you are trying to treat a TM joint pain or any other musculoskeletal pain in the body for that matter. The dosage is 5 joules per centimeter square. What is 5 joules per centimeter square? Difficult for me to explain in this session because again you'll have to go for the basics of laser therapy, area, how much time you have to give, how the dosage can be changed. We are not discussing those things. Remember, your cutting laser machine cannot be used for healing. If you want to do healing, you'll have to take a separate machine for healing. That can be used for mucosal lesion, used for facial pain. You have a tip where you can put hypochlorite inside the root canal and then cure it. For all those purposes you can use. You cannot use it for cutting. You take it from me. It is comparable to arthrocentesis. That is what the studies are telling, and definitely patients will have significant pain relief. And when should you do? Probably every day or alternate day. You'll have to call the patient at least for a period of 15 to 20 days. Slowly you will see that the pain is getting relieved. Now it is for you what you will choose. TENS therapy. TENS machine, you can buy it. It is available for 2,500 rupees to 5,000 rupees available in the market. You can keep it in your department or clinic. Or if you are attached to a hospital, wonderful TENS machines are there. Refer the patient for TENS therapy. But please mention patient's diagnosis. Where do you want the TENS to be given? Which area? And how much time? 15 minutes for 5 consecutive days is more than sufficient for TENS. There is something called as MENS. This is a modification of TENS machine called microcurrent nerve stimulation. This is a recent study published by our Mangalore people, Dr. Junaid and colleagues. They have shown that MENS works better than TENS for TMD pains. So both can be done, both can be used. Both can be used and both effectively manage pain. Now, coming to therapeutic ultrasound, excellent modality in combating pain. Excellent modality. Now again, you'll have to speak to your physiotherapy department people and ask what is the machine they have got. The ultrasound means again you will have to see the frequency of the ultrasound transducer that they are using for pain relief. For TM joint, you will require around 3 megahertz. You should not give it for more than 6 to 8 minutes. It will have some adverse effects, they say, on the periosteum. You have to give it only for 6 to 8 minutes, and maximum you will have to give it for 1 to 3 weeks. And how does this act? This ultrasound acts, it reduces inflammation, it causes muscle relaxation, it increases blood flow. Remember, it is also causing muscle relaxation. Very, very important tool. Now, when you are choosing a particular modality, the studies say that the success rate is good for almost all these modalities. But remember, once you start these modalities, if you don't see a significant relief in 4 or 5 days, better stop it. Don't continue. If the patient is giving a response in the initial 4 to 5 days, then there is use in continuing these modalities. If the patient is not at all giving any response, there is no point in continuing these modalities of treatment. So studies have shown that physiotherapy, the success rates are similar to splint therapy. I am not telling. Studies are telling. And what studies are telling us is you start the patient on physiotherapy. If the patient is getting little better and if you are not getting complete relief, then you switch on to a splint. What you are choosing, I leave it to you. What I am doing, I am telling. I am not following the step care model. My first line of treatment will be muscle relaxants, analgesics, that is the paracetamol. And if the patient is a chronic patient, start with a splint. We have not come to the discussion of splint set. That is yet to come. So now coming to splints. There are so many splints available in the market. So many splints that are favorites for dentists. There is something called as hard stabilization splint. The hard splint which is made out of acrylic. Soft splint that is made up of a polymer. All these things we order it to the lab and then get it done. Or if it is a college, prostate department people or ortho people will do it. There is something called anterior repositioning splint. There is a prefabricated splint. Most of the people with this airway problems, they get these prefabricated splints. They push the palate so that they don't get this sleep apnea. So something similar to that, we also have prefabricated splints for TMD. You can find it in Amazon also. There is something called as a mini anterior splint. And there is a different kind of a splint which is designed by orthodontic people. They call it as a deprogrammer. Now, what is the importance of splint? See, a recent study has evaluated about 46 randomized controlled trials. You know what it has concluded? 92% is the success rate for an anterior repositioning splint. Of course, the quality of evidence is little low, but 92% is a big number, my dear friends. Second one, combined therapy, and HSS stands for hard stabilization splint. Combined therapy means you are treating the patient pharmacologically, also with a splint, or you are treating the patient with physiotherapeutic modalities and splint. The success rate is around 67.3%. And hard splint alone, it is 52.9%. And they concluded from these studies that multimodal therapy gives maximum improvement. Now, how do you choose a splint? What exactly does a splint do? Now, I want your attention here. You know what is this? This is a study published by Annals of Anatomy. What they have done here is, they have done functional MRI studies. In functional MRI studies, what they have seen is, they have seen cerebral activation changes. When I was talking to you about central sensitization, I showed you a picture, green, yellow, and red balls, if you remember, the brain regions. You know what they have done in this study? Before and after splint therapy, they have subjected the patients for functional MRI. And what they have seen is the neural function of brain regions, it is changing. There is a demonstrable change in functional MRIs after the splint therapy. Therefore, they have also suggested that a central mechanism underlying the therapeutic effects of splint therapy is there. So splints are very, very good in managing these conditions. So what are the materials used? Hard acrylic resin, soft and resilient polymers. Dual laminated splints are available. Hard on the occlusal surface, soft on the opposite side. In my experience, you should not be using soft splint because studies are not supporting soft splint, number one. Number two, you imagine if we give you a soft item, something like an eraser, and if we keep it in your mouth, what will you do? Will you keep it without doing anything? No. What do? We tend to bite. So a soft rubbery polymer is not good in the mouth. Neither the studies are supporting it, nor the feature that I have explained. So it is always better to give it is called anterior repositioning appliance or an anterior repositioning splint. What exactly does this splint do? This splint basically should be given for disc displacements, whether it is with or without reduction. How to fabricate this splint is, now let us say this patient, I have given an example here, is having a bite like this. You have to do a bite registration with wax or a rubber based material. Bite registration material comes separately. You can use anything. Wax is also fine. You ask the patient to bring the lower jaw forward to an edge to edge bite. So you are repositioning the mandible. You are advancing the mandible to facilitate this anteriorly deranged disc to go back to its original position. That is the idea of giving this splint. All other things are also happening here. Your joint is getting rest, patient is not clenching, muscle hyperactivity is not happening. All those things are happening. Along with that, we are trying to reposition the disc. So in this position, you make a wax bite, take upper lower impression, send it to the lab. You will fabricate a splint like this in acrylic. You will have indentation of upper and lower teeth. Mandible is repositioned, and you will have to wear. Remember, all splints have to be worn only in the night time. No need of wearing it for the daytime because it will cause irreversible occlusal changes. Maximum changes in the occlusion will happen with this kind of splint. You ask me, if you give a patient anterior repositioning splint, in my practice, what I do is I give the splint and I call the patient periodically once in 15 days. And I keep looking at the occlusion. Luckily, if the patient says pain has disappeared, I'll immediately stop that splint and give him a regular splint, a flat stabilization splint done in normal occlusion. So this is the guideline that you will have to follow. According to me, up to 2 to 3 months I have given for most of the patients with no occlusal changes. But in a prolonged manner, you should not be using this. How does a splint work? Alteration of occlusal condition, alteration of condylar position, cognitive awareness. Patient will be aware of this problem. It has got a placebo effect, and it is also decreasing the motor activity by avoiding the clenching. So splints form the mainframe of the therapy, but splints can aggravate respiratory disturbances in people with chronic sporing and sleep apnea. So please take a thorough history before giving a splint. And when should you give a splint? You can give it for myogenic problems. You can give for bruxers. You can give for arthritides. If there is a disc displacement with or without reduction, probably your first choice should be an anterior repositioning splint. Otherwise, a hard, flat stabilization splint would suffice for all the patients. For all the patients. Again, I am telling you, splints are very, very important in managing TMDs. Now coming to most important thing, behavioral intervention. See, you might be thinking this is all theory. My dear friends, in my experience, I am telling you this is not theory. There is something called as cognitive behavioral therapy. This particular modality works wonders. It is done by clinical psychologists, not by psychiatrists. So if you have an access to good psychologists near your clinic or in your hospital or in your institution, please take their services. Please take their services. In this cognitive behavioral therapy, it is basically something like counseling where they make the patient aware of the cognitive condition. They will take about 8 to 10 sessions, and they will charge somewhere ranging from 800 rupees to 4,000 rupees per session, depending upon where they are practicing, what is the standard of practice. That is, of course, we are not bothered about that. But I am telling you, this cognitive behavioral therapy is very, very good in managing TMD patients. If at all you see a psychological etiology, please send them for cognitive behavioral therapy. Please don't give them only splint and keep quiet. Send the patients and you will get to see the wonder. I'm telling you, I'm doing this for the past several years because fortunately we have access to psychologists and psychiatry department. If you are practicing in an institution, yes, you need to do this. In the morning when I started my presentation, I told you it is very difficult for me to cover everything in this particular lecture. Now there are so many other modalities which are enlisted with good degree of success. I am not speaking about that because one thing is it is very difficult to use and I am not using it. For example, arthrocentesis. There is a Cochrane review which says that arthrocentesis is a very good modality, but since it is invasive, I don't use it. It has become very fashionable for people to use Botox. Again, we do not know the results. And I will tell you the problems associated with this Botox therapy. Each injection of Botox will cost you 35,000. After giving Botox, if the pain does not come down, what answer are you going to give to the patient? Right? See, these problems are associated with these things. Injection of steroids, of course, the oral surgeons, some people, it is their favorite treatment to give for TM joint. I don't recommend because there is no sufficient evidence for that. And there is one funny treatment. Let me tell you. If you remember the first slide in the management, I had told you about IMF. I had told you about rest to the joint is best to the joint. One of my teachers told me that he used to do this. In my 20 years of practice, there are about 3 patients for whom I asked my surgeons to do IMF. Everything else failed. I told the patient that as far as my knowledge goes, I have tried everything. I want to do IMF. I told them what is IMF. I told them for a period of 1 to 1.5 months, I'm going to lock your jaw. You'll have to eat from the side, like how fracture patients are eating the same way. So for these 3 patients, I had done IMF. They have given very good responses. Pain totally disappeared for these patients. And I'll tell you another funny thing that happened. After 4 years, that one patient came back with his friend and told that you please do this treatment for this person. I asked him what is the reason, has he got TM joint pain? He said, no doctor, with your treatment, my pain disappeared and at the same time, I lost around 11 kgs of weight. Now this friend of mine has tried multiple modalities to lose weight with no degree of success. So please lock his jaw so that he will lose his weight. This was just an experience that I felt I should share. So there are a lot of other things, arthroscopy, open joint surgery, which I do not recommend. And it is definitely not in this time frame, it is definitely not possible to discuss these modalities. So finally, I would like to give one guideline. Since many general practitioners are sitting here, if you already know that patients are suffering from TMD, and if you want to perform dental treatment for those patients, there is a guideline that you need to follow. Number 1, 3 days prior to your dental treatment, start hot compresses to masseter and temporalis. You need to start hot compresses to masseter and temporalis. You can start the patient on muscle relaxants 2 days prior to the treatment. And you can start the patient on NSAID on the day of procedure. Probably start chlorhexidine 2 days prior and start paracetamol on the day of the procedure. Preferably keep charter appointments, do multi-sitting RCTs, stop the treatment in between, give some rest, massage the muscles, and please continue muscle relaxants for 1 to 2 days post-procedure. It is especially important in extractions and impactions, continuing muscle relaxants for 1 to 2 days post-procedure. So while doing dental treatment for TMD patients, please remember these things are very, very, very important. This is the guideline that you need to follow. I come back again. TMD may be temporary and self-limiting, so please avoid aggressive and non-reversible therapy for its treatment. With this, I would like to end my talk today. See, I might have not covered so many things, or I might have not addressed few things that you people have felt it as important and I have omitted it. All said and done, I am also a human being. If you feel there are any mistakes and there is any misinformation that I have given, please bear with me. And many, many thanks for a patient listening. And finally, I acknowledge my teachers for everything. Thank you.
Thank you, sir, for the exhaustive session on the management of temporomandibular disorders. It's now time for the question and answer session. I request Dr. P. Durga Devi, Assistant Professor, to take over the Q&A session. So you can stop sharing your screen, sir.
Okay.
Yes.
I think it has already stopped.
Just now, sir. Thank you, sir.
Yeah.
Thank you, ma'am. And thank you, sir, for your wonderful lectures. Here we'll start with the Q&A session. We have a few questions posted by the participants, which we would like you to answer, sir.
Yeah.
So the first question was posted by Dr. Aravinda. The latest evidence links bruxism to obstructive sleep apnea, and what is your take on this? Your opinion on this?
I very much agree. But I am not for giving appliances for sleep apnea. In my experience, what I have seen is it is causing malocclusions and TMDs. I might not have seen many patients, but definitely I am not for this. I am still a strong believer that BiPAP and CPAP are the recommended treatments for sleep apnea.
So the next question was posted by Dr. Stephen. The role of biofeedback therapy in TMD and the role of dry needling and iontophoresis in TMD.
Dry needling, I have already spoken on that. Iontophoresis is definitely you can try. There are good studies showing iontophoresis. It can be coupled with the ultrasound and used. And regarding biofeedback, most of the studies are showing good results, but I have not tried because there are no good labs giving biofeedback appliances.
Next question is by Dr. Shanmati. Do orthodontic treatment cause TMD problems?
I don't see a reason why orthodontic treatment should cause TMD problems. No. On the contrary, if a patient is having a severe TMD problem, I feel the orthodontist should wait for a month or two, manage the TMD symptoms, and then go ahead with orthodontic treatment.
Next question is by Dr. Mobit Gupta. The impacted tooth itself is not causing TMJ pain. So can the TMJ pain can be due to pain from the pericoronal region and the malposition of that impacted tooth? Do you agree with that?
See, if a pericoronal inflammation is causing unilateral chewing, yes, definitely it can cause TMD. But again, the position of the tooth has nothing to do with TMJ. Hello?
Yes, sir. Yes, sir.
Yeah, parafunctional habits like mouth breathing, nail biting, yes, there is sufficient evidence. But things like nail biting and all, it should be prolonged. There are some people who are continuously doing it. In them, yes, definitely it can cause TMD. Patients with inflammatory bowel disease also be evaluated for TMDs. Most of these patients don't have definitive diagnosis as they might give us symptoms of IBS. No. See, why should we start seeing? If you want, you can do a study on that. But if the patient is symptomatic and the symptoms are to an extent where it is unbearable, he will seek treatment. We don't need to go and see IBD patients for TMD. No need to do that. On a research interest, you can do that.
Her question was on like all the TMD patients should be evaluated for IBD.
We can just take the history, man. If you take the history, if the patient is giving history of bloating, repeated constipation, diarrhea, and if he's not on treatment, no, you can ask him to consult an enterologist and immediately start treatment. Because see, there are so many people where the symptoms might not be to an extent where he might seek treatment. But you can ask them to seek treatment, and if concurrently both conditions are treated, it can be managed in a good manner.
Next question by Dr. Rishad. The link between Meniere's disease and TMD.
Meniere's disease, see, this is very much debatable. See, Meniere's disease is nothing but tinnitus with some other symptoms. See, in my clinical practice, you know what happens? These tinnitus patients are little headache patients. Once the ENT says, gives a green signal, they come and sit on our head. They say, please do something. Definitely, they have shown that there is improvement in symptoms of Meniere's disease if you are managing TMDs. But they should have TMD for that, no? For 1 or 2 patients in the past, I have also given a night guard, but I have not seen that the symptoms improve. But 2 cases is nothing. It is useless evidence. First of all, it is anecdotal data and the evidence is useless. Because it's very difficult to comment on Meniere's and TMD. Articles are telling there is an association between C-spine, TMD and Meniere's. All 3 put together. But how far can we help in treating isolated Meniere's? I don't know. And definitely TMD might not cause Meniere's. And if you go and see, there are so many things where people are trying to debate that what you are having is actually TMD and not Meniere's disease. If patients are having TMD with significant symptoms, they will definitely seek treatment. Then we can take care. Looking at the current evidence available, we cannot go and treat Meniere's with splints or anything else. What is this?
Next question by Dr. Anand. What about the quality of life in TMD patients?
Quality of life.
Yes.
I feel most of the patients, first episode patients or intermediate patients, they are all fine, doing well. Unless and until they have comorbidities or chronic patients or patients with psychiatric problems, their quality is little compromised.
Next question by Dr. Divya. When should we use stabilization splints and when do we go for arterial repositioning?
I think we have addressed this particular thing. When you have a disc displacement with or without reduction, you go for a repositioning splint. Use it for a period of 2 to 3 months. Once the symptoms subside, you come back to a flat splint.
Next question by Dr. Mathu Jatta. What is the treatment for a patient giving history of orthodontic treatment, complaining of clicking sound while opening his mouth?
Don't treat. If there are no symptoms, why do you want to treat? And please don't tell them that orthodontic treatment has caused clicking. No, it can't cause.
Next question by Dr. Vihang. What is your take on biometrics instruments for diagnosis of TMDs?
Very difficult because I have not used it.
The next question by Dr. Kamath. How long should we use muscle relaxants? Like how
For
long
a period of, at least for a period of 1 to 2 weeks. Not only that, I would like to give an example here. This muscle relaxants, no, it should be a regular modality of treatment for chronic TMD patients. I will tell you what will happen. Imagine there is a patient who is under treatment for chronic TMD. There is a disc displacement with reduction. They are wearing a splint and they are religiously following all home care instructions. Suddenly she goes to a party. She feels like eating a burger or a pani puri. Because there is no pain, she gets tempted. Immediately she eats that. Next day the pain pops up. Again, you remember, even if the patient is on long-term splints and long-term other treatment modalities like pregabalin or amitriptyline, additionally, you give them 1 week of muscle relaxants. Very, very important. So minimum 1 week, maximum till 2 weeks, you can give the muscle relaxants.
Next question by Dr. Sabita. How thick the splint should be?
About 2 millimeters. It should not be very thick to have an effect on the occlusion. It should not be very thin so that it will break.
Next question by Dr. Nileta. Patient with clicking sound and without pain, with patient having bruxism, can we give splint?
Yes, you have to give a night guard, hard night guard.
The next question by Dr. Lokapriya. Should we get physician opinion to provide an alternative to SSRI in iatrogenic bruxism?
I didn't get you. Physician opinion for prescribing buspirone.
Yes, sir. SSRIs.
Huh?
SSRIs for in case of iatrogenic bruxism.
Yes, you require. Yes. See, not only that, just giving buspirone will not suffice. They will have to stop SSRIs. That is the first thing to do. And buspirone is relatively safer. It's an anti-anxiety drug. It can be prescribed. Not an issue. But let me tell you, whenever you are prescribing antipsychotics, antidepressants, immunosuppressants, always better to take consent, safer side.
Sir, and how long this SSRI should be prescribed?
Pardon me, how long?
This SSRIs can be prescribed for the patient.
Can be stopped.
No, what is the duration we should prescribe the SSRIs for this patient?
No, ma, see, we are talking about buspirone, right? Are we talking about SSRI-induced bruxism? No.
Yes, sir. No, the question was about SSRI-induced bruxism.
See, SSRI-induced bruxism, you have to ask the psychiatrist to prescribe an alternative medicine. There are a lot of other antipsychotics available. Once the patient develops a bruxism, if you are planning to restart the medicine again they will have bruxism. So you will have to go into a different group of drugs, probably trihexyphenidyl, escitalopram, things, drugs like that, citalopram. Okay.
The next question is by Dr. Vijender. Is it a hot application alone or cold application alone, or you can use a combination of both to treat TMJ problem and myalgia in the temporal area?
See, there are studies quoting everything, but if you look at the longitudinal studies, alternative hot and cold application is given good results. See, I am telling you one thing in hot application, one should remember. See, you should not ask the patient to put hot water bag on the muscles. No. Dry heat is not advised. It should be moist heat always. Either you tell the patient to put hot water in a bowl, use a handkerchief, dip it, and then put moist heat on the muzzle. Or you take a turkey towel, put it in hot water, then you put the hot water bag, wrap it in a turkey towel, then it becomes moist heat. You'll have to use that. Dry heat should not be used. So for about 30 seconds, you give heat therapy. For 30 seconds, you put a ice bag, or you put ice chips or ice cubes in a handkerchief and keep it. So alternative hot and cold will be better.
Next question by Dr. Jayanta. Can pyroxicam be used for the relief in TM joint pain?
Pyroxicam?
Pyroxicam for TM joint pain relief.
Yeah, why not? Anti-inflammatory medicine, but why do you want to use it? That is my question. Why not paracetamol?
So the next question by Dr. Shanmati. Is myofascial pain dysfunction syndrome is related with TMD problems, or what is your take on it?
It's not clear, madam. Can you please repeat the question? Myofascial pain dysfunction syndrome?
Is it related with TMD?
Yeah, of course. Patient will have early morning discomfort in opening the mouth. Jaw deviation will be there. Clicking will be there. It is definitely myogenous TMD. Only the terminology has changed. That's all.
Next question by Dr. Shanmuga Priya. Why do patients with TMD complaints of burning sensation in the preauricular region, and what is the treatment for the same?
Come again.
Why patients with TMD complaints of burning sensation in the preauricular region, and what is the treatment for the same?
See, burning sensation, they say it's basically again a little centrally mediated. There is no sufficient data on this, but if you are not able to combat that with muscle relaxant, better to start amitriptyline. Better to start amitriptyline.
So next question by Dr. Rashmi. Can Radomed map of pain help in diagnosing TMD?
No, ma.
There's a question by Dr. Shubhangi. How can we diagnose COMT polymorphism?
Diagnose what?
COMT polymorphism.
I didn't get you.
COMT polymorphism.
That's a laboratory investigation. Don't bother about that. And we will never get a chance to do it in our clinical practice. It's all in research studies.
There's a question by Dr. Biham. How to treat a patient who has cervical issue associated with TMD?
How to treat a cervical pain?
Yeah, cervical pain associated with TMD.
Okay, first thing is you'll have to do a referral. Establish the diagnosis. What is the cause for cervical pain? Based on that, they will treat. They will either give a neck collar, they will do interferential therapy for the neck muscles, or they will add physiotherapy, or they will also give drugs like pregabalin, because most of this radiculopathy, the drug of choice is pregabalin. So it is a combined mode of treatment. Physiotherapist, orthopedician, and yourself, all three put together can treat these problems of cervical musculature. And nowadays there are a lot of shoulder and neck specialists, super specialty in orthopedics. You can send the patients to them. See, all these cervical issues and muscle generated issues apart from TM joint area, orthopedicians and physiotherapists are very, very important for you. And you should have one group.
So one last question by Dr. Priyadarshini. What is the line of treatment for TMD with reduced mouth opening? Can we advise mouth opening exercises for the patients?
Well, what is the cause of the reduced mouth opening? That we need to ascertain first. If the cause of mouth opening is something like a protective co-contraction or a muscle spasm, then relieve it. use a muscle relaxant or give to a dry needling. But if the cause of decreased mouth opening is a lock because of disc displacement without reduction, then you have to give a splint and wait for months together.
Okay, sir. Thank you so much for answering all these questions with patience. Over to Dr. Sabita now.
Thank you, Dr. Durga and Professor Srinivas, for your interactive Q&A session. We would now like to thank the speaker of the day, Professor Dr. K. Srinivas, for delivering such wonderful lectures and emphasizing the importance of the comorbidities associated with the temporomandibular disorders, along with the management of the disorders. Thank you, sir, for joining with us and sharing your knowledge. And as a token of appreciation, we would like to present an e-certificate to you. Kindly accept our e-certificate, sir.
Thank you very much, ma'am.
Sir, it's for you, sir. The
Thank you very
feedback
much.
link will, welcome, sir. Feedback link will be sent in the chat box during the vote of thanks, and request all the participants to fill the feedbacks to receive your e-certificate. Marcus Cicero states, gratitude is not only the greatest virtues, but the parent of all the others. It's now time to show our gratitude. I invite Professor Dr. P.T. Ravikumar, Head of the Department of Old Medicine and Radiology, and the Organizing Secretary of Radomed2k21 to propose the vote of thanks.
Good evening, all. It's honorable guests, my dear colleagues and participants. On behalf of organizing team, Department of Oral Medicine and Radiology, Vinayaga Mission Sankaracharya Dental College, I, Dr. Ravi Kumar, feel immense pleasure to take this opportunity to propose vote of gratitude to our eminent speaker, Dr. K. Srinivas, MDS consultant of Manipal Hospital, Bangalore, who spared his time in spite of his busy schedule to grace this webinar in the topic of TMD and update. He enriched us with wide knowledge about TMD. I hope this session was very fruitful and beneficial to all the listeners over here. Thank you, sir. I take this opportunity and express my gratitude to our chief guest, Professor Dr. J. Sabrinathan, Director of Academics of VMRF DU, who could spare time for us. My deep gratitude to our beloved Dean, Professor Dr. Baby John, for his unaltering support during this pandemic in conducting webinars and boosting us always with confidence. My sincere thanks to Dr. Sivakumar, Professor of, and Dr. Dhyani and other HODs, professors, and all faculties of various dental colleges for their immense support and presence. I also extend my thanks to all the clinicians and my friends for being part of this program. Success of great event, it is not possible without the dedication of hard work. So let me acknowledge my colleagues and postgraduates for their enduring support and tireless work to run this program successfully. My heartfelt thanks to all the participants who choose to join with us and attend the webinar till the end with the great enthusiasm and to make it successful event. Last but the least, my extend gratitude to the event manager, Dr. Mr. Nadarajan and K. Sundareshan for the technical support and helping our webinar through the Zoom and YouTube live. Once again, thank you all for being a part of Radomed2k21. Be safe, meet you soon.
Thank you, sir. We are into the most awaited moment of today's event. It is the distribution of prizes for the quiz winners. I now request Professor Dr. N. Mohan to announce the winners of the quiz.
Screen share already.
screen you want to share, sir?
This.
Then go to sharing screen.
Okay. Started. Okay. 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 I'll stop. Okay. Am I audible? Yeah, good evening. Thank you for this opportunity. I once again thank everyone on behalf of the organizing team. I particularly thank all the participants for the quiz and the prizes for the quiz, as was announced before, is 3 third places and 1 second place and 1 winner or top place. So the sharing the 3 third prizes. The first name for that is Dr. Farakat Khan. Third prize. Third. Third place. So the observation is all the people who obtained the third place have got 63% with accuracy. The next person who wins the third place is Dr. V. Pungodi. Dr. Priyadarshini gets the other third prize. Dr. Sukanya D gets the second place. And the winner of today's Radomed2k21 quiz is Dr. Jatin Lonyal. Congratulations, all the winners. Very well done. In fact, I think it was an excellent performance. I congratulate all those who participated in both the preliminary and the final round. Thank you. Thank you very much.
Thank you, sir. Hope all of you had a great learning. Let's part for now with the hope of a new learning experience tomorrow. Thank you all once again for your active participation. All of you can leave the meeting.